Good morning. I hope everybody can hear me, and welcome to the 17th Annual Kawasaki Disease Parent Symposium. We're delighted to have you joining us this morning. We've got lots of exciting information to share, and we're so happy that you joined us. A few housekeeping details. Para Español, our Spanish interpreter, wonderful Lucia Acosta. If you will hit the interpretation button at the end, bottom of your screen, select Spanish and unmute the original audio. Otherwise, you're going to hear two voices coming at you. So thank you, Lucia. For questions, we really welcome questions. We want to answer questions from parents. This is for you. And there is a Q&A function at the bottom of the screen. We are not going to be using chat, so please put your questions in the Q&A, and we will be answering those questions in two halves, one at the end of the first session, and then again at the end of the second session. So here are our fabulous presenters. And I'm not going to go through all the introductions. They're going to introduce themselves, but it's a fabulous group of people who are going to be educating us about Kawasaki disease this morning. This is the agenda. So there's a first session with talks. Then there's going to be a 30-minute Q&A. So we're really serious about wanting you to send in your questions, because again, this is your symposium. And a celebration following that for the KD Foundation 25th anniversary. So an exciting presentation by Greg Chin. There will be a very short break at that point, and then we'll resume with talks for the second half. And at the end of the second half of talks, there will be another 30-minute Q&A session. So if we don't get to all of your questions in the first 30 minutes, stay on, and hopefully we'll get to them in the last 30 minutes. So let's get started. I thought I would give you an update on what's been happening at Rady Children's Hospital in the last year. And these are the numbers that we have over roughly the last 10 years. There are some notable features. One is that if you look in this year, you can see that we've already had over 80 patients, and we still have 2 months to go. So it's been a busy year. And in general, when it's not the pandemic, we have between 80 to 100 new Kawasaki disease patients at Rady Children's Hospital. And these are children from our surrounding community. We serve a catchment area of maybe about 3.5 or 4 million people. And that's what our life looks like. During the pandemic, you can see in 2020 and 2021, there was a remarkable dip. And we know that something about the mitigation strategies for the COVID pandemic is what caused that dip. So masking, school closure, social distancing, some or all of the above was what was operational to cause that dip in cases at that point. So here's the distribution in terms of ages of our patients. About 70% of our patients are under the age of 5. Maybe patients are a little bit older these days. You can see in the orange color, those are our babies, our patients under a year of age. So it's our smallest group of patients, but it's also the group we worry about. And Dr. Dummer today is going to talk to you about how we especially care for those patients. And in the other age groups, the biggest category is the 1 to 5-year-olds, because that's the peak age incidence for Kawasaki. And maybe this year we have a little bit more of the older children, so almost a third of the patients have been over the age of 5, so school-age children. So that's the scene in 2025. And here's what we found in terms of their echocardiograms. So a typical scenario is that a patient might be admitted to Rady's in the evening or at night. They might get their IVIG overnight and then get their first echocardiogram the next morning. And on that first study, we can see here that almost 70% of the patients had a normal study. And if that continues to be normal when we see them back in our clinic at the 2-week visit, then they would be classified as American Heart Association risk level 1, which is the best. And you can also see that 15% in blue of our patients were dilated on that first echocardiogram. Beyond that, another 15% or so had small aneurysms, and a very small percent, that 2.8% in that maroon color there, actually had very worrisome aneurysms. Nobody had a giant aneurysm on presentation, and all of those children who had abnormal echocardiograms at Rady Children's Hospital are going to get intensification of initial therapy. That means that in addition to IVIG, we're going to give your child additional treatment, and at our hospital, we use infliximab, which is also known as Remicade, and it's a monoclonal antibody that blocks the inflammatory pathways, and we've had great success, and Dr. Dummer is going to tell you more about that in her talk. So Chisato Shimizu in our group and Laurel Dehan, who's a member of our Kawasaki disease climate team, have been using the Pediatric Health Information Service database to do some fascinating research about what Kawasaki disease looks like across the United States. So the hospitals that you see marked here with the little spots are the 45 freestanding children's hospitals that participate in the FIS, as we call it. And you can see the distribution is heavily weighted towards the East Coast, but we also have sites along the West Coast. And from these sites, Dr. Shimizu has gone through the training to be able to access the data from these sites. So one of the questions that we wanted to ask is whether the seasonality, meaning the months of the year when we see the most cases, is the seasonality for infants, so our youngest population, is it the same as older children? And the reason that we were interested in looking at that is that, and this is going to be dealt with a little bit more by Professor Jen Burnley, who is the lead in our climate team. And we noticed that in the Japanese data set, and she's going to be presenting these data, that it looked like there was a different seasonality for the infants versus the older children. And why would that be interesting to us? We wanted to ask that question because at the moment, we don't know the causes of Kawasaki disease, but there's certainly a lot of data that suggests that the youngest patients, those are the infants under 12 months of age, may have a different kind of exposure or be reacting to something different than the older children. So in this graph that Laurel created from the data on the FIS, we can see with the color coding the different age groups broken down. So the infants under 6 months of age are shown in the very dark blue. And the school-age children and older toddlers are shown in the other colors, and the key is up here in the top of the slide. And what you can see in these very dark highlighted peaks is that the seasonality of the infants, because we're looking now at months of the year, so we start in January and we go across to December, and when the school-age children are having their peak, which we generally think of Kawasaki disease as a winter-spring illness, but in fact, that seasonality, that concept is really driven by what's happening with the older children, the children who are out and about, outside of the home, going to school. And the infants, who may be more likely to be closer to home, have a very different pattern. And this really argues for the idea that there is a different trigger for these youngest babies as compared to the older children. And we see that they're not participating in this peak in the winter, spring, and then they have their big peak in the late summer and early fall. And the dark highlighting is a statistical significance marker that just says that these are significant deviations from what the rest of the population is doing. So I wanted to provide you with some links. If you're QR code savvy, you can use these QR codes to link you to the KD Foundation website, and a shout out to the KD Foundation who are helping to sponsor this program. We're deeply appreciative every year that they do this for us. Our website, where there's a lot of information in many different languages for parents, and a direct link to the resources for parents at that bottom link there. So we invite you to visit the website and partake in the information that is there. So a shout out to our research group. You're going to be hearing from many of these members today, and we're really delighted to be able to share the information that everybody's been hard at work generating this year with you. So with that, I'm going to pass off the talks to my colleague, Mike Gardiner, who's our emergency room lead, and he's going to share with you the research that's going on there. But we are really privileged to have such a great set of colleagues in the emergency department at Rady Children's Hospital who are so aware of this disease and help make the diagnosis on a daily basis. So Mike, over to you.
Thanks, Jane. Let me pull up my slides because multitasking is not my biggest strength, but let's see. And we will display. All right. Well, like Jane said, my name is Mike Gardiner. I'm one of our emergency physicians at Rady, and I've had the pleasure of doing quite a bit of work with the Kawasaki group. And I met Jane and Audrey when I first started working here back in 2017, and I've been doing a handful of research studies since then. But this is my first time getting the honor to present to this group, so I'm really happy to be here and to get to share some of what I've been working on and what we've been working on as a team in terms of accurate diagnosis. So in the emergency department, we don't give IVIG, we don't treat Kawasaki disease. So my role within the team has primarily been working on the diagnosis. And so trying to figure out the best ways that we can identify children early and get them into the hospital, get them treated, and hopefully prevent any bad coronary outcomes. So before I get in specifically to my work, I just wanted to highlight some of the work that we as an emergency department have done in conjunction with Dr. Burns and Tremoulet and the rest of the Kawasaki team that really was spearheaded by my predecessor, John Kanagai, who is down in the bottom right there. He's been doing decades worth of work on Kawasaki disease and the emergency medicine implications, so the diagnosis of Kawasaki disease. And he really started this collaboration with the Kawasaki team that I've been fortunate enough to continue with. So we've had open research protocols collecting information and samples from many children who have Kawasaki disease, as well as those who have similar looking diseases. So kids with fevers and rashes and big lymph nodes in the neck and red eyes, and kids who do not ultimately get diagnosed with Kawasaki disease. And for over a decade now, we've been collecting clinical information and blood samples on, as well as some other urine and some throat swabs and things that really has allowed the ability to fuel this research that we do both through the emergency department, and then those samples are used, they're invaluable samples that are used for a variety of other studies, from some of the other research that will be touched on today, but a lot of the gene expression studies and the genetics of Kawasaki disease to really try to answer a lot of questions about KD. So we're really appreciative to all of the children and family members who have helped to provide samples to us for this. And I'm sure there are some on this call and many on this call, in fact, who are a part of this research. And it's really invaluable and has created one of the biggest data sets of Kawasaki disease in the country, and probably the biggest in the country, and one of the biggest in the world, to allow us to answer a lot of these questions. So like I said, really my personal focus in the emergency department has been much more on the diagnostic side. So I'm going to talk to you today about some of the work we've been doing with clinical prediction models and artificial intelligence. But Dr. Catherine Pade, who's the middle picture here, she's one of our ultrasonographers in the emergency department. So she's looking at the ultrasound characteristics of Kawasaki disease. And then we've also been doing some work with some folks at Cornell looking at blood samples and urine samples and working to develop new diagnostic tests using some new RNA technology. So lots of different things that we do through the emergency department. But today I wanted to focus on what we've dubbed Kawasaki Match. So this first came about from the pandemic, as Jane alluded to earlier. I don't know if people on the call remember this from the media, but there was a condition called multisystem inflammatory disease in children, or MISC, that came about as a result of COVID-19 exposure, and thankfully has since disappeared. So we're not seeing that anymore. But during the pandemic, when MISC was a thing, there was a lot of funding out there for research. And one of the things that came out of that was the development of this machine learning tool. So we worked with our colleagues over in the biomedical informatics group at UCSD, and through the data in the Kawasaki database, as well as the data that we were ongoing collecting, we developed this tool using the age of the patient, the 5 clinical signs of Kawasaki disease, and the 17 lab values that I have listed here. And our biomedical informatics colleagues developed a machine learning tool to provide a score to predict the likelihood of Kawasaki disease. The initial version also predicted the likelihood of MISC, but with that disease no longer bothering us, we've pared down this algorithm to really be a Kawasaki disease predicting tool. So the first paper that we published from this was published in the journal called Lancet Digital Health. And in that, we showed a 90% accuracy for diagnosis, which is a really strong predictor. 90% seems like an okay number, but in terms of these diagnostic scores, anything over 90% is fantastic, especially for a disease that's as difficult to diagnose as Kawasaki disease. So with the pandemic getting past us, and with the MISC disappearing, essentially, we asked the question, does our tool continue to perform well? So this is a second study that we published in a journal called the Journal of Pediatrics back earlier this year, so early 2025, where we looked both at a new set of data from Rady Children's, but then we also asked for some help for some friends. So we had some friends at Boston Children's Hospital, at Children's Hospital Colorado, and Children's Hospital Los Angeles, who provided additional patient data for us to test this algorithm on. And so the picture I've given here is just to give a brief background and description of what sensitivity and specificity looks like. So if this is a representation of the entire population of children in San Diego or Boston or Colorado, and we look at the figures in red as kids with Kawasaki disease. Accuracy is more or less just a measure of, for every patient that we see, so for all the red patients and all the black patients, how correct is the tool? So in the red patients with Kawasaki disease, how many times is it saying they have Kawasaki disease? And in the black and gray patients here without Kawasaki disease, how often is it telling us that they're okay. They do not have Kawasaki disease. So that's the accuracy. Sensitivity is specifically looking at the red patients, at our Kawasaki disease patients. So it is how well is our tool performing within the patients that have Kawasaki disease. So how often are we missing a case of Kawasaki disease, essentially, with a high number being good, a low number being bad. And then specificity is the opposite. So it's how well is it performing in the other children, the children with viral illnesses and non-Kawasaki disease illnesses. And again, high numbers are good, low numbers are bad. So as you can see here, our tool performed very well. And in particular, it performed well, overall accuracy, but performed even better within the Kawasaki disease patients. So our sensitivity was very high, 94%. That means for every 100 patients with Kawasaki disease, it correctly identified 94 of them, which when it comes to diagnostic tools in medicine is about as good as we can get. And we're still trying to be better, but that is a really strong performance. And it means that we're not missing many kids with Kawasaki disease early on. And this serves as a nice screening tool to really raise the alarm to our emergency providers of, hey, you need to think about whether this kid has Kawasaki disease. And then that can fuel the next steps in the diagnostic process. And then as you can see in the bottom table, this performed very well additionally on the cohorts, the additional patients that we got from our friends at Boston and Colorado with Kawasaki patients, as well as CHLA with patients who did not have Kawasaki disease. So the next steps in terms of analysis, once we know that this works in theory, is we start testing this in reality. Like what happens when we actually give this tool to providers? Because not every provider is going to trust a machine and a score. And so it's not going to be so easy as, oh, the score says you have Kawasaki disease, we're going to treat you. So what we did, we've done this in a couple of stages. This study is not yet published. We just finished data collection and are going to start disseminating this to conferences and hopefully get this study published within the next couple of months. But what I did is I asked several of my friends in the emergency department, so folks who do my job in our emergency medicine physicians, to look at case vignettes. So these are cases from children who really did present through the emergency department, and I looked at the medical records and created a scenario. And the providers read through the scenario, look at the labs, look at the physical exam, and the providers tell me, I think this child has Kawasaki disease, and what's next? Am I going to send this child home, or am I going to admit them to the hospital? And then what happens from there is up to the hospitalist team. So we did this a couple of different ways. We started by having the providers just tell us by reading through the scenarios, and then we took the provider accuracy and compared that to Kawasaki match, compared that to our machine learning algorithm to see, does the computer more accurately predict, or do these experienced emergency providers predict better? And then we went back 3 months later, so enough time for folks to not remember the details of the cases, and we had them do the cases again, but with Kawasaki match to see if it changed the performance, if it changed how we were treating the children. And here are the results. So we had some really, really promising results in this. And so the first thing is these were tough cases. And I looked at these even after I had written them, and they were really difficult cases. Even the kids who didn't have Kawasaki disease were not obvious. And so our providers on first pass had 67% accuracy, which seems low, but these were really tough cases. Despite that, Kawasaki match had an 82% accuracy. So they actually, not only did the algorithm do better on average than the providers, but the highest scoring provider on this test had 78% accuracy. So Kawasaki match was better than all the individual providers as well, even our best of the 21 that took the test. With the 67%, thankfully more than that, they wanted to have the child admitted because they looked ill. Even if they didn't think it was Kawasaki disease, they thought the best next step was to have them in the hospital. So 83% of the time they wanted to hospitalize the children, which hopefully would have ultimately led to the diagnosis. But as you can see on that 3 month later test, Not only did the providers get more accurate, so their accuracy rose to 73%, still less than the algorithm said, but thankfully, even better than that is we hospitalized almost every child with Kawasaki disease in this hypothetical scenario. So 98% of children were hospitalized, and even the ones that they didn't think had necessarily had Kawasaki disease would have been in the hospital to have more eyes on them and more time to figure things out. So that improvement, especially that 98%, I really love seeing come out of these results. So hopefully we'll get that published soon and get that information out. And so what's next? Right now, we're in the middle of what we call a randomized clinical trial or a randomized controlled trial, which is one of the gold standards in medicine of the best types of research. So as opposed to what we've done, which is looking at vignettes that were derived from real patients, it's not the same as seeing a patient in front of you, right? And we as emergency physicians really pride ourselves on the in-person interaction and being able to see the patient and do the exam ourselves rather than read about them. So we're doing that. And we are, when children show up to Rady Children's Emergency Department with fever and rash or fever and red eyes, whether they look like they definitely have Kawasaki disease or probably not, we're asking families to be a part of this research study where we're providing samples and providing information, but we're also testing this tool. So we're randomizing our providers where half of the time they're being asked to diagnose this child based on their own clinical expertise and their own experience like we always would have done in the past. And then the other half are being asked to use Kawasaki Match to log in, enter patient information, and get a risk score. And then we're taking that to look at, again, how accurate is Kawasaki Match, but how is it influencing our providers? How is it leading to earlier diagnosis? Is it leading to better, more accurate diagnosis? Are we sending less kids home early in the course of Kawasaki disease? And ultimately, are we preventing coronary outcomes? Are we preventing problems with the hearts of these children? And that's the save the world type goal. So we're really hopeful. This project or this study has been enrolling patients since March of this year, and enrollment has been fantastic. We've had a lot of enthusiasm from my colleagues in the emergency department. Separate from that, some of our next steps that we've been working on, we've been talking to, again, some colleagues from not just in the US, but we have a network in Latin America and some folks in Asia, in a group in China and a group in Japan who were hoping to be able to run this algorithm on their patients, because every patient population is different. The population in San Diego is different than the population in LA and Boston, but it's also very different from the population in Japan. So we're hopeful that these international cohorts perform well additionally. And then with this machine learning technology, I'm not a computer scientist, but we're really hoping to utilize the technology that's out there, in particular in large language models and AI photo recognition, to add additional layers onto our prediction tool. And like I mentioned, always trying to get better. And then we have to figure out how to get this out there. You know, we've done a lot of validation on our populations here in San Diego, but as Jane mentioned, our emergency providers are very experienced in Kawasaki disease. We've seen a lot of Kawasaki disease, whereas folks out in the community, in rural hospitals, in urban settings, I think that's where this is going to become really crucial. And I'm excited to figure out ways to get this in the hand of more providers and get more children diagnosed early and do a lot of good for Kawasaki disease. So I ran over time like I always do, but I very much appreciate everyone's time and attention. And I'm really excited that I got the opportunity to share all of this with you. And I will silence myself and unshare my slides and pass it on.
Thank you, Mike. It was great to have that presentation. And we also want to acknowledge the Macklin Foundation, which is funding the work that's ongoing and the research that's ongoing with KidMatch. We also just made the decision yesterday to put the code for this physician support tool into GitHub, which is a repository for these kinds of algorithms. And so the code will be available there, and this is going to be the way that we facilitate our international collaborations. So a huge shout out to the Macklin Foundation. So over to you, Dr. Dummer.
Okay, good morning. Thanks for having me here today. I'm going to talk today a bit about the youngest population of patients with Kawasaki disease. So let me get my slides up here. Okay, there, you should be able to see them. So this is my task, is to speak to you today about the very youngest patients with Kawasaki disease. And I'm a pediatric cardiologist, and now I focus most of my clinical efforts in this rare disease, Kawasaki disease.
Kirsten, can you put it in presentation mode?
Yeah, it
Just
should be.
click on the bottom.
There you go. Is that better?
Yep.
Okay, perfect. So this is a CT scanner. This is the machine that we use to image the coronary arteries in the patients where we're concerned about aneurysms. And so the patient lies here on this flat area and then is moved through the scanner. And the picture on the right shows kind of what normal coronary arteries look like. So when we get these data sets, we have them recreate three-dimensional pictures for us. And this shows us, in a general sense, the coronary arteries, obviously from the outside of the vessel, not from the inside of the vessel. But this is, in general, what normal coronary arteries look like in terms of being kind of uniform and then getting smaller as they course around the heart. These are pictures from infants, very young infants, who were transferred to our institution after having been treated for their acute disease at outside facilities. So as you can see, just in a general sense, these look very different from normal. And this red area is the aorta that brings the blood out of the body, and the yellow are obviously the coronary arteries that course around the heart to bring blood flow and nutrients to the muscle. These are babies who have had aneurysms because of their acute Kawasaki disease and the course of their illness. And this is the dreaded complication of Kawasaki disease that we are trying to prevent with earlier diagnosis and various treatment strategies. So I want to talk a little bit about Z-scores, which is how we talk to you about coronary arteries. So these vessels are very, very small, and particularly when we're talking about the smallest of our patients, they are incredibly small. And as you can imagine, by ultrasound, it is difficult to measure this internal diameter in a beating heart. And so we have a lot of challenges, although we've gotten very good as a medical community, both from our technology advances, and this is really bothering me that I have to keep doing this. But in any event, we measure the coronary arteries from the internal dimension. And then we use the body surface area to index them. And then we compare them to everybody else with the same body surface area. And so a Z-score is kind of a comparison statistic tool. And so if you have a Z-score of 0, you're at the average of the average. And this is the bell-shaped curve of the normal distribution of coronary artery sizes. So normal is really between a Z-score of -2 or 2 standard deviations below the average of the average, or +2. So there's a large distribution of sizes that can be considered normal. And then out here on the tail end is where we have Z-scores that are bigger than +2. There's going to be a percentage of the normal population that falls at the upper level of this, probably it's about 1.7% of the population is going to fall in here naturally. But we don't know what people's baseline coronary arteries are. So when we see patients and they have a Z-score of between +2 and +2.5, that's considered mild dilation. Often that gets better very quickly. Once you get a Z-score above 2.5, this becomes the territory for when we say that patients have aneurysms. And pretty much now around the globe, it is agreed upon that there are ranges of which we say that a patient has a small aneurysm, or a large aneurysm, or a giant aneurysm. And so the Z-scores of greater than 10 are the Z-scores of these patients that have very giant aneurysms. So who is at high risk? I saw a question already posed in the Q&A section. Well, we know that patients that are diagnosed late and get treated late are at high risk of having coronary artery abnormalities. We also know that at the extremes of age, they have a higher likelihood of abnormal coronary arteries, so less than 1 year of age and then greater than 10 years of age. Asian ancestry carries a higher risk. And we know that infants less than 6 months of age are the highest risk, even when you diagnose and treat them within the 10-day window. So there's something different about these babies. And it has been published multiple times in several different demographic areas. And it's known that about 50% of the infants less than 6 months of age have an abnormal first echocardiogram, meaning that the coronary arteries do not measure within normal on the very first time that we look. And then of the patients who initially have a normal scan, 20 to 30% of them in the literature go on to have abnormal coronary arteries during that illness. So this is an incredibly high number of patients who have coronary artery abnormalities related to Kawasaki disease, even despite timely diagnosis and treatment. So there is an American Heart Association statement on Kawasaki disease initially published in 2017, but recently updated in 2024. And there are some distinct differences. We used to have to wait for 5 days of fever before the diagnosis could be made based on the guidelines. Now, that wasn't how it happened in practice because there are experts around the country who obviously feel comfortable diagnosing that sooner, but now it's actually written and it's part of the statement that experienced clinicians may establish the diagnosis earlier, even at 3 days of fever. And we have diagnosed patients at Rady Children's Hospital, even I think the earliest I saw was 2 days, but this is now an acceptable practice. And in fact, we think this will help change some of the outcomes. The other important difference in this statement, or I should say one of the important differences, is that now it says that substantial data indicate that the right coronary artery or the left coronary artery, when you have a Z-score greater than or equal to plus 2.5 at the time of diagnosis, and you are a very young patient less than 6 months of age, across different racial groups, that the patient should be considered for intensification of therapy. And I think Dr. Burns mentioned that word intensification of therapy in the beginning. And what that means is that you're going to give the patient something other than, or in addition to, IVIG. So there is no clinical data that compares the treatment approaches in the Western population. So the standard of care is to provide IVIG. Across the board, everybody provides IVIG. But then when you know that you have a high-risk patient, what else can you give? So there was a period of time when people would give a second dose of IVIG. As many of you know, IVIG takes a long time to infuse, and it has some risks associated with it, particularly in patients with certain blood types. But now we have better medications and therapies available to us. So we no longer do 2 doses of IVIG. That's incredibly rare practice in our center. Steroids are very common and they're prevalent and they're relatively inexpensive and they're widely accessible around the world. So steroids can be used as an intensification of therapy, but we know steroids have a lot of side effects. They require prolonged oral administration. People have to go home on tapers. They can have high blood pressure. They can have behavioral changes. And it's not known whether or not steroids are the best agent for the acute intensification. In our institution, we use infliximab or Remicade, as Dr. Burns had suggested. This is a single IV infusion and it runs over 2 hours. So actually, there are now about half of the time where we will give infliximab first, even when they're in the emergency room or as they get to the floor, because it's easy to administer, it's accessible, and it doesn't take as long to infuse. So sometimes we will now give infliximab first before we give our IVIG. So these are really the most common options for the acute intensification of therapy in the high-risk patients. So we wanted to look at our infant outcomes, and I had a sense when I came here 7 years ago that we just didn't see a lot of giant aneurysms in the babies, and I was curious as to why that was. So we combined our data with Colorado Children's because we both have a similar approach to treating these high-risk patients. And it turns out that over the last 10 years, there's been 71 infants less than 6 months of age admitted to either one of these institutions, diagnosed and treated within 10 days of illness. And about 79% of them received acute intensification, and about 98% of the time, it was with infliximab. There was one patient who received a second dose of IVIG. So the reason why these babies got intensified were because many of them already had coronary artery differences on the echo. 5 of them had resistance, which means you give the IVIG and then within 36 hours, they have a return of fever. 5 of them just looked very ill, might have had Kawasaki shock or just looked highly inflamed. And so it was at the opinion of the treating physician to give another medication. And 1 of them had both coronary artery differences and IVIG resistance. And 16 infants received additional therapies beyond IVIG and infliximab. So this is another pie chart that looks similar to the one that Dr. Burns has, but not as colorful. And of these babies, when they were first admitted, again, like the literature states, about half of them, or 45% of them, had normal echocardiograms. And then 46.5% of them had abnormal echocardiograms. So we actually had 1 patient that had bilateral giant aneurysms on admission. And then we had 3 patients that had medium-sized aneurysms, and then 29 patients with small and 6 with very mild dilation. And of these normals, we had 38% that became abnormal. So just like the literature states, it's a very high number of times then the babies become abnormal. These are line graphs that show single patients where they started with their Z-scores and where they peaked with their Z-scores and where they ended up at a year out. So we used a year out from the acute illness as our end point for this data. And you'll see that of these 10 patients, many of them had medium to giant aneurysms during their illness. And this was, despite the fact that we had given IVIG and infliximab and then even some other medicines. But all of them, except for very few, ended up with either normal coronary artery sizes or very mild dilation at 1 year out. So this is like a really important outcome because 59% of those patients were normal at a year. 7 patients had minimal dilation at a year, and 5 patients had small aneurysms. And so this is quite extraordinary when we think of how many of them had medium and giant aneurysms and how high risk they were to begin with. So the important thing is that not a single patient had persistent, moderate, large, or giant aneurysms, which meant that we did not have to use any systemic anticoagulation or dual blood antiplatelet agents. And so the question was, is this favorable outcome due to the early diagnosis and the acute intensification with infliximab? Possibly, right? We don't know what the cause and effect was, but we know that the babies did incredibly well considering the high-risk group that they are in. So there is a proposed trial to determine which agent may be best, and that would be very helpful for the world to know what agent we should use to prevent these drastic outcomes. So thank you very much. Happy to answer questions at the end.
Great. Thank you, Dr. Dummer. That was wonderful. And I am going to jump in now with a presentation about diagnosing and predicting outcomes. So following on with Dr. Dummer's presentation, we all have experienced as providers or as patients and families that the diagnosis of Kawasaki disease can be challenging and problematic. So you've heard about artificial intelligence, and now we're going to be talking about a blood test. First of all, to introduce the story of a case control type of study design, and I think this has already been discussed by Mike a little bit previously, but when we talk about case control studies, we're talking about cases being the Kawasaki patients and controls being children who have other rash, fever, illnesses that could be confused. Unfortunately, the medical literature on Kawasaki disease is, I might say, polluted by a lot of studies that have claimed to have created a diagnostic test for Kawasaki disease. But if your control group isn't a group of patients where a doctor might think that they have Kawasaki disease, then that's not the right control group. So if you use children, for example, with respiratory disease, you all have been through Kawasaki disease, and you know that that terrible cough and those kinds of symptoms are not a big part of Kawasaki disease. So those would not be appropriate control groups. And so it's very, very important when you look at the literature, you look at claims of research groups who have created a diagnostic test, that the control group really was a group that someone thought might have had Kawasaki disease. And in fact, in our control population for these studies, almost 50% of those children who come into our emergency room, and again, shout out to our wonderful emergency room for enrolling the patients in these studies, 50% of the patients who are our controls were actually sent in by a clinic or by a doctor because of concerns that the patient might have Kawasaki disease. Now, it turned out that they did not, but that makes them a very valuable control. And that's the group that you really want to have for your control group and comparison group. So a little bit of molecular biology, heads up here. We're going to be talking about RNA molecules. So we start with DNA, that's the genetic code in every cell in our body that encodes all of the information that each cell needs to function. And the DNA then needs to get turned into RNA, and these are complementary molecules that are made from the DNA template. And then once you have the RNA, those molecules then need to get translated into amino acids, which form a chain, and they fold, and those create proteins. So understanding what cells are making and why is what we find out when we study proteins. Focusing on RNA really tells us something about what the cells were thinking. So we're going to be talking about RNA. And specifically, we're going to be talking about a population of RNA molecules that are outside of cells and floating around free in the blood. And we call this cell-free RNA. And through a really exciting study now funded by the Macklin Foundation, we are working with the team at Cornell. I'm going to introduce them in a second. And we're studying these free RNA molecules floating in the blood. And where do they come from? Well, in Kawasaki disease, we're discovering that many of them come from the blood vessels or from the heart or from the liver in a subset of patients. And when cells die, you can sort of think of their spilling their guts into the blood, right? I mean, when a cell blows up, its body parts need to go somewhere, and they end up in the circulation. And so we see these bits and pieces of free RNA floating there that tell us about injured cells, because that's where those pieces came from. They also can come from cells that are rapidly turning over. So again, dying cells that have their body parts spill into the circulation, and we can find them there. And that's what cell-free RNA is. So a huge shout out to Ewan de Vlaminck at Cornell University and his fabulous laboratory there doing the sequencing and helping with the bioinformatics of understanding what these segments mean, and students and graduates from his lab who are also participating in this research. So basically, we have to sequence the RNA, and that involves a process of converting it into a complementary DNA, amplifying it, putting it in a big machine that then reads out actually the nucleotide sequence. So it's a sequence of molecules that we can then hook together, we can then map back to known sequences, and we can know what cell they came from. So the way we do case control in this situation, not like what they do in the emergency room, here we're actually doing case control with molecules. And these are segments of RNA. So this is the cell-free RNA. And we're looking at what is in the blood of the Kawasaki disease patients. And again, we use only 400 microliters of plasma. So this is a tiny, tiny several drops of plasma to isolate these RNA molecules. And then we compare the population of RNA molecules in the Kawasaki patient versus our controls. Again, children who somebody thought might have had Kawasaki disease, but they don't. They have a different inflammatory illness. And then we do a bioinformatic adventure, which we call a volcano plot, as shown here. And let me walk you through what an actual volcano plot looks like. This is a scatter plot that we use to visualize the results by displaying the magnitude of how much more of that fragment is in our disease population of interest. So obviously this is Kawasaki disease for us versus the control population. And we look at the statistical significance, which is on the y-axis. So that's the axis going up, and across we have the magnitude of the change between these two groups. And then we can identify each of these RNA molecules, what they are, what that sequence was part of a larger RNA molecule. And we know that we name it for the gene that encoded it. So you can see here that we have a group of markers in red that were increased in our population of interest, for example, Kawasaki disease. And then based on that volcano plot where we have RNA molecules or transcripts, we call them, that were elevated versus in one disease versus elevated in the control disease, we can create a score, a classifier score. And in this case, we took 12 transcripts, so 12 of those highly expressed, highly abundant molecules. Based on the volcano plot, we created a score, and then we took a training set, that means a group of Kawasaki patients and a group of controls, and looked at how well that scoring system based on those 12 transcripts differentiated the two. So you see the Kawasaki people, we had 71 Kawasaki patients, so very small numbers here for this kind of statistical effort. But with the funding from the Macklin Foundation, by the end of the year, we will likely have well over 1,000 of these samples sequenced and be able to really dig into the bioinformatics and come up with a much better classifier score. But you can see already with these small numbers, we have a classifier score. If you take the dotted line going across, these are populations that are being fairly well separated. And then once you do your training, you go to a test set. Now, this is an independent group of patients, an independent group of Kawasaki disease patients and the controls. And now you look at how your test performed. And again, we can have pretty good separation. It's not perfect. It's going to be much better once we get larger numbers to test. And then we take the performance of our classifier score, and we want to look at the true positive rate and the false positive rate. And we do that with a statistic that we call area under the curve. And what you're looking at here is a graph that if the test were perfect, if this axis here is the false positive rate, we don't want any of those. We want that number to be small. And then the true positive rate is here, and we want that, we want that number to be big. And if we look at the line, what we want is the true positive rate to go directly straight up and then across, so no false positives. Well, that would give us an area under the curve, so the blank space would be 1, and that would be a perfect model. If it were 0.5, that would be like flipping a coin, and obviously that's not a helpful test. And then the values somewhere between 0 and 1 indicate how well our test is performing. And right now, with the very small numbers of samples that we've had, so limited statistical power, but We already have in our training set an area under the curve of 95%. Remember, 100% is what we're going for. And when we took that same classifier score and put it in an independent population, our test group, we had an area under the curve of 90%. So obviously we want to get up to 100%. We're working on that. And things are looking so good so far that we're pretty confident that we will be able to create a blood test for Kawasaki disease. The good news about cell-free RNA is that it is very straightforward to convert that into a test called polymerase chain reaction, or PCR. And PCR-based tests are being used every day in every hospital laboratory across the country. And the head of our hospital laboratory has already jumped up to be first in line to be the beta test site for this test when it comes online. So we also want to learn about the biology of our disease, and we want to be able to predict. We want to be able to predict who's going to get aneurysms and who's going to be resistant to IVIG, and we could give them more therapy right up front. So here's where the AI and machine learning come in. So our input data, shown as vegetables here on the left side of the slide, our input raw data has all of these RNA molecules mixed up, okay? So all kinds of vegetables. And we can put it into an algorithm that looks at, without having any classifiers, so the computer doesn't know which molecules these are. All the computer knows is that there are a group of patients who all look similar. And the output then is it organizes this population into groups that look similar. So the bell peppers all went to the top, the eggplants in the middle, and the onions on the bottom. And so this is what the machine learning process can do. It can take a complex mixture of information and then sort it into groups where they look similar. So let's move now back to science instead of vegetables. And we've got a system to predict coronary artery aneurysms that we're working on, where in this particular example, and again, the numbers will get much larger as we move forward, on the left side of the slide, we took 138 patients and all of their cell-free RNA, all mixed up. And we put it into the unsupervised learning. Again, the computer didn't know who was who, but the computer was able to bunch the people who looked like each other together. And now we go over to the right side of the slide where we have our group with aneurysms that are shown by the red bar at the top of what we call the heat map. And the blue bar shows the patients who did not have aneurysms. So these are all Kawasaki disease patients. But the computer was able to see that in terms of the population of cell-free RNA, there was a specific pattern in the aneurysm patients, and it grouped them all together. And so where there was a lot of transcript, those transcripts were shown in blue, so that's a low level. And where there were high levels of that RNA molecule or transcript, it was shown in yellow. So you can see that even with this small number at the beginning of this study, the computer is able to predict who is going to get aneurysms. Now, the important thing is this blood was drawn in the emergency room. This blood was drawn before the patient was treated, before the patient had received a firm diagnosis of Kawasaki disease. We are already able to predict, and going forward, this should get even better, how to predict aneurysms. So we're very excited about this capability. I'm going to end there with a lot of excitement about a bright future. I really think we're going to make the world a better place for these children. Thank you. Okay, and now we're going to turn it over to Greg Chin for a celebration of the KD Foundation. Greg?
Hey, Jane, thank you very much. I thought we had in the slot here a Q&A, but I'm happy to go right now. So, all right, well, I'm going to get my slides going and I'm going to get a share on. All right. So I want to
Q&A after your session. Sorry.
Oh, no problem. Thank you. All right. Can you all see my slides here? Just a little thumbs up. Great. So I want to thank the organizers and UCSD. We've had a really great partnership since the very beginning.
Greg,
I
not
also want
yet.
to
We
thank.
don't see your slides. We don't see
Oh,
your.
okay. No problem. Let me relaunch this.
Still waiting.
Okay.
Still waiting.
Can you see it now?
We got it. Now put it in presentation mode and we'll be all set.
Okay, here we go. How's that?
We got it.
All right. Thank you for bearing with me. And thanks again to the team at UCSD. You guys have been great partners since the very beginning. I also want to thank Vanessa, who's our board president, for these awesome slides, but also especially for helping to take KDF to the next level. And I want to thank you all for joining us for this 25-year celebration of the KD Foundation. It's hard to believe that we're at 25 years. I never thought when this all started that it would result in this. So I thought maybe it would be helpful to go back to the beginning of how this all started and think back 25 years ago. And I think about what's changed and what's the same, right? So in terms of what's the same, a lot of the things that we face today and I hear about are the stories that are very much like what our family experienced from KD the first time. In fact, just over the summer, I got a call from a mom whose child they thought might have KD, and she was very much in the dark and reaching out for help and support. And so we had connected her with some folks. And that was very much like our experience. But what's new and different today is the technology that's available. We're very excited about that. So to kind of give you a little bit of history on how this all started, I'll take you all the way back to 1998. So this was when our son was diagnosed with KD, and it was very much a journey. And during that very first year, we were searching for answers. And if you remember back then, it was 1998. This was pre-internet, really. I mean, the internet was just forming. There were no smartphones. Email was the killer app. And while we were searching for information, I came across this Kawasaki disease listserv. And it was a way for families to sign up for a listserv and exchange emails. I think it was one of the earliest forms of social networking. And on this listserv, parents were kicking around the idea of having a parent meeting, bringing professionals to parents, something that had never been done before. And I thought, well, we can do it here in Boston. We were very lucky, and we had access to great doctors who treat our son. And so I had reached out to the team at Children's in Boston, and they had connected us to the team at UCSD, and we got to meet Jane, and that's really where things took off. And so while I did take the first step, I didn't travel this road alone. There were a lot of other parents and volunteers who were involved. And that symposium became the genesis for the KD Foundation. So the foundation was founded on these three pillars here: supporting families, educating the public and medical community, and help promote and fund KD research. So we believe that our work would help bridge the gap between parents and professionals, ensuring that no one faces KD alone. And we believed very early on that even though as parents we're not medical professionals, through education and awareness, we could save lives. So these are some of the milestones of the foundation over the last 25 years. It's the National KD Awareness Day on January 26th, a KD biorepository and DNA bank, global symposiums and virtual events. So events like this, but also participating in the every few year IKDS. In fact, I think we've participated in every one since 2001, and also having done other parent symposiums throughout the country. We've also funded over $500,000 in research, and we recently launched a KD Youth Internship Program and the Dr. Tomosaku Kawasaki Memorial Scholarship. So these milestones reflect the power of community, science, and compassion. And we believe from a single symposium to global research and partnerships, we've grown into a trusted voice for KD families. And our investments in research and youth leadership are shaping the future of KD care. So these are some of the programs that are the backbone of the foundation. The KD Bridges program, it supports families by connecting them with trained and trusted parent volunteers. We host an annual KD Parent Symposium with UCSD. We recently launched the KD Youth Internship Program and the Dr. Kawasaki Memorial Scholarship. So whether it's through finding comfort through Bridges or teens discovering purpose through our internship, we believe that we're there every step of the way to support you. So these are some of the examples of some teen volunteers that I wanted to highlight here. So Ava Quinn, she's a former KDF graduate school intern and healthcare transition advocate. She was inspired by her cousin Ethan with his journey with KD, and she developed the HCT toolkit to help teens transition from pediatric to adult cardiology care, paving the way for KDF's upcoming healthcare transition app that empowers youth independent health management. So what I love about Ava's story is it shows how family experience can spark innovation and advocacy, even if you weren't a patient yourself. I know Ethan and I know his mom, and she's been a great support of the foundation over the years. And the next one is Emily Rodriguez. So Emily is a KDF youth intern who was diagnosed with KD at age 2. She's been active since 2024 in leading awareness campaigns, engaging in social media outreach, and representing KDF at the Mount Sinai Adult Congenital Heart Disease Symposium. Her advocacy blends personal experience with public education, inspiring young survivors to share their stories. And what I love about Emily's story was her mom had reached out to us probably 15 years ago to get involved. And so it's amazing to see how that spirit of advocacy and volunteerism has transitioned from generation to generation. And we believe that these are the young leaders that are helping to shape the future of KD care through empathy, creativity, and action. And we can't have a KD event without acknowledging the man who inspired all of this. Dr. Kawasaki, his discovery didn't just identify a disease, it gave families hope and saved lives. So we launched the Dr. Kawasaki Memorial Scholarship. It was created by us to honor Dr. Kawasaki and support students affected by KD pursuing careers in medicine, science, and public health. It aims to inspire future KD advocates and leaders. And the KD Awareness Day observed on January 26th was Dr. Kawasaki's aha moment of discovering KD and emphasizes early diagnosis. So we conduct annual educational campaigns around this day to honor his contributions and amplify the voices of KD families, continuing his mission. So it's not just a date, it's a tribute to the man who gave families hope. KD Awareness Day ensures his legacy lives on in every life we touch. So we honor him not only through remembrance, but through action, by continuing to educate, support, and innovate. So looking ahead to the future, what's next for KDF? We believe the next chapter of KDF is about innovation, inclusion, and impact. By investing in youth and families, we're building a future where KD survivors become leaders, advocates, and change makers. We're proud to support innovative research efforts like AI tools for early KD detection and studies exploring new treatment options, while strengthening global partnerships to ensure every child has access to timely, effective care. And so with your support, we'll continue to fund research, empower families, and save lives. So how can you help be part of the mission? You can volunteer, donate, and raise awareness. Whether you give your time, your voice, or your resources, we're helping to save hearts and change lives. Every action, whether big or small, brings us closer to a world where no family faces KD alone. Together, we can fuel hope, fund research, and build a stronger KD community. So I want to thank you for being part of this journey. It's been amazing 25 years. And here's to the next 25 years of hope and healing. So thank you. Hopefully we've saved enough time for Q&A. I don't know if you have any questions for me or for the foundation. I'm happy to take any.
Greg, thank you so much for that journey. It's been an amazing 25 years, and congratulations on all the achievements of the foundation. So if everyone could turn the presenters in the first half could turn their cameras back on. Again, I want to remind everybody that we're trying to have you use the Q&A, not the chat, for your questions. And Dr. Adriana Tremoulet has been busily jotting down all of your questions as they've come in, and she is going to either answer them herself now or distribute them for answers to the group assembled here. So take it away, Audrey.
All right, I've done my best to start to group these, and I'll try to do task also by keeping an eye on the Q&A. The first question, maybe we can have you do this, Dr. Burns, is about the relationship of Kawasaki disease with other illnesses. So I know we've had our adult study that was graciously funded by the Macklin Foundation as well, and really being able to figure out what is the association between KD and other illnesses. So I'll leave it at that because there's several people chiming in about that.
So if I could put a plug in for the presentation that Dr. Bhatt is going to be making later in the morning. He is our adult cardiology team member at the San Diego Cardiac Center. And we are trying to learn more about the long-term health outcomes of our Kawasaki disease population. And we are continuing the adult KD study, which is a questionnaire-based study that goes for 20 years after the children have been discharged from our clinic. And we're hoping to collect information about how patients are doing and what their health outcomes are, as well as the health outcomes of their children. This is a genetic disease, and these children have the possibility of passing on their genetic pattern to the next generation, and we're trying to collect data about how often that happens. But in terms of other diseases that are known to be linked genetically to Kawasaki disease, we do not have any front runners there. We do know in our population of children that atopic dermatitis or eczema is overrepresented. This is something that the children have had usually before they get Kawasaki disease, but again, it's a genetic condition, a skin condition, and it does seem to be linked to Kawasaki disease in that studies of large populations in Asia, particularly Taiwan, Japan, and China, have found an association, and we've had small studies here in Western populations that also seem to link those. But other than atopic dermatitis, we don't have any strong links to any other diseases. And of course, when a child has Kawasaki disease and then 10 years later develops X, Y, or Z, there's always a tendency of parents, it's very natural, to say, I wonder if that was caused by or linked to their Kawasaki disease. But right now, we have no evidence for any disease later in life that might be linked. Great,
thank you. This is for Dr. Dummer. It's a question about the long-term use of aspirin and when it's indicated. In particular, there's a family that's posted a question about a child with dilation. So at what Z-score might it be recommended to be on long-term aspirin?
That's a great question. It depends on where you think normal is, right? So we tend to stop the aspirin when the Z-scores are around +2 is what I would say. There are times when the vessel looks abnormal or doesn't taper, and maybe we keep it on for a little bit longer. But in general, the normal vessel should be a z-score of between -2 and +2. So when it gets down to around +2, +2.1, we tend to stop the aspirin. If it remains abnormal, then we keep the patient on medication for as long as it remains abnormal.
Great, thank you. There's a question, and maybe this is best answered by Dr. Burns, about siblings. Are kids with siblings who had giant KD aneurysms at risk of getting KD? So maybe you can speak to the work with the different sibling work that we've done with twins.
So Kawasaki disease is fundamentally a genetic disease. Most parents don't have a history, a personal history of having had Kawasaki disease. And that's because Kawasaki disease requires a complex genetic pattern in order to be susceptible. And most of the time, one parent has part of the susceptibility genes, and the other parent has the other part of the susceptibility genes. And every time you make a new human being, you roll those genetic dice, and you end up with a new combination. So when a child is born and has the full pattern to be susceptible, a second thing has to happen, and that is they have to have the exposure to the trigger. Now, we're pretty sure from the experiment of the pandemic that it comes in, it's something they breathe in, and that triggers their disease. Obviously, we're all breathing the same air, and none of us are bothered by it. But if you are the susceptible child, that trigger causes Kawasaki disease in that child. If you have siblings, if that child has siblings who are older or who could have been younger, but who were alive at the time that that child got their Kawasaki disease, all those siblings are breathing the same air and having the same exposures. Those siblings are never going to get Kawasaki disease. They do not have the full genetic pattern. So you don't have to worry. They are not going to get it. In terms of multiple children in the same family who get Kawasaki disease, we only see that in the setting where there was an unborn child at the time that the first case had their Kawasaki disease. And then later on, another child is born to those same parents into that family, and they may also have the risk. If the first child had giant aneurysms, we are not seeing 100% concordance. That means the same fate for the next child in that family who has Kawasaki disease. And that is likely because there are genetic determinants that influence susceptibility, and there are additional genetic influences that are important for whether or not you develop the aneurysms. So if the question is a second child in the family, when a first child had giant aneurysms, the second child may not develop giant aneurysms. I hope that answers it.
Great, thank you. It's a complex issue, so we appreciate that. We're going to go back to Dr. Dummer. We've got some questions about aneurysm regression. So just to give an example, there was someone who posted a case of their own child who, as you said, was high risk. They were a 1-month-old, diagnosed with KD and had multiple aneurysms. It's now about a year later, and the question is about the possibility for regression. So can you just speak to the question of how these aneurysms may regress, if they may resolve, or sort of the long-term outcomes of those aneurysms for giant aneurysms in particular?
Sure. So, I mean, in general, we think that the largest amount of remodeling occurs in the first 2 years after the acute illness. So kind of what you're at 2 years later is what we think is how you're going to stay, more or less. The way that these vessels remodel with giant aneurysms is that they actually layer down clot against the wall of the aneurysm. And that's because of kind of how the flow works, the velocities through a big aneurysm. So as the child lays down this clot, against the wall, which sometimes you don't see that by ultrasound because it's a thin layer. Then they heal over that. It's almost like they heal their own, I say skin, but it's obviously not skin. They make different, endothelial cells, and then they layer clot, and then they make cells. And so you get a thicker wall, but a smaller dimension of a lumen. And that's how these vessels remodel. So what you get in the first 2 years is basically how you're likely going to stay. And the remodeling occurs by really layering thrombus against the wall. And then later on, that can develop into calcification. So it's really important that patients with giant aneurysms have imaging surveillance with CT scans at some infrequency throughout time. We tend to look at the giant aneurysm patients definitely a year out from the illness. And then depending on what we see, it might be every other year by CT scan. And they require really close follow-up to look at the heart muscle function. So we see those patients every 6 months at a minimum. And eventually it's important that they get some sort of what we say ischemia testing to challenge the heart and see to make sure that there's enough blood flow going through all those diseased aneurysms to the heart muscle. And that testing can take place in a variety of different ways. I guess I'll leave it there unless there's further questions.
No, that's great, because that also answered, somebody had asked about long-term imaging for aneurysm patients. So you you guessed that question well. I'm going to take a couple of questions that are here about follow-up. So there's questions about when patients should be follow up, how frequently they should be followed up. And having just been on the writing group for the 2024 American Heart Association statement, which was a big pleasure for me, the follow-up can be confusing, and it can in part be confusing because it can be different depending on where you live. So if you're with us in San Diego, I will tell you what we do here, which is we follow all of our families, no matter about what their heart outcome is. We follow all of our patients until they're at least 15 years of age. If you have any coronary artery abnormalities that we think may be long-term or we're on the larger side, you'll hear from Dr. Bhatt shortly from the San Diego Cardiac Center, who's an adult cardiologist that we're privileged to work with. And he has been following the patients that need long-term care, but we follow everyone until they're 15. Now that's different than what is in the AHA statement, and that's different than what's maybe done at many of your centers if you're not following up here in San Diego. So everybody gets seen in the hospital, everybody gets seen within 2 weeks or so from going home, hopefully. And then some centers will follow you up at 6 weeks, and some sites will follow you up if you have normal coronaries, you may be seen at a year. But some places just, after you've been seen once in the outpatient setting, at the 2 to 6 week visit, you may be discharged from care if your child had no coronary artery issues. The frequency of follow-up, besides that, depends on the heart ultrasound and the center. So it is center to center dependent, but everyone gets to be seen at least once in the outpatient setting, and many places are following up at the 1-year visit as well. Hopefully that answers that. I don't know if Dr. Burns or Dr. Dummer have any further clarification on that, but I think there were several questions there. All right. Yes. Dr. Burns?
I might just chime in and say that the genetic counseling piece we think is really important.
Thank you. Yeah.
For these teenagers. Most of these children were too young to have any personal memory of their Kawasaki disease or what happened. And we feel that age 15 sort of onward is a sweet spot for when children are old enough to understand the concept of genetic counseling. And it's very important for them to know about this. So they're given a sheet when they're discharged from our clinic that's a kind of passport that describes their Kawasaki disease, what happened to them. It's just a single sheet. We have them take a picture of it on their phone because they're never going to lose their phone, right? So that's going to be an important piece of information for them to carry forward in their life. And we definitely want to plant the seed and convey the message that this illness can be passed on genetically to the next generation, and they just need to be aware of that, of what Kawasaki disease is and what their experience was.
Great, thank you. So one other question that had come up was if we are providing any information back, and maybe this is a good one for you, Dr. Burns, for folks that have contributed samples to any studies. I know Mike did a live answer for one question about this. There was another question that came in. Are we providing any patient-specific results back to families?
So as I described in the segment about cell-free RNA and that research, you can see that we're looking at groups of patients. So we don't actually look at individual results, we look at groups of patients. So in that particular study, we do not analyze the results by individuals, and we don't give results back to the patients. For our genetic studies, and thank you to all of you who have participated in our genetic studies, similarly, we look at groups of patients, we look at the transmission of genes from each of the parents to the child who we know has the full genetic pattern. The only time that we give feedback to people, and in the last 4,000 participants, this has happened twice, so I'd say it's pretty rare. But if in working with the DNA, the laboratory discovers a known mutation, and this happened in 2 of our moms who happened to be carrying a mutation for a gene called factor V Leiden that is associated with a high risk of blood clots. And when and if that should happen, the laboratory notifies me. I have a way on my computer of rejoining the study number with a name. And those 2 individuals were notified about this finding because this was potentially important for their health. They had it verified in a formal genetic testing laboratory. It was verified, and they were grateful. You really don't want to hear from me about your DNA, because it would be about a mutation that is known to be associated with a disease that we feel ethically you would like to know about. It's very rare that that happens, but again, that's the only way that you would hear back any individual results from all of our research studies.
Great, thank you for clarifying that. I don't know if Greg Chin from the KD Foundation is available to come on. There was a question about finding care in other parts of the country. So one person that wrote in was asking about finding cardiovascular care in the city of Dallas, as an example. And so I wonder, with maybe our families ask us, and if we know someone in that area, we'll of course refer them to someone. But I wonder if there are other families out here that may be in other areas, if the KD Foundation, like with KDF Bridges or otherwise, would be a good resource for them. So thanks.
Yeah, we get those kind of calls quite often. And so often our first outreach is to doctors like you in the community, connect into your network so they're known KD experts, but other times we'll reach out to families that we may have in the area that are maybe have had an experience with a doctor who's known, and we can connect. But we're always trying to bridge those communications. So it's often connecting with the doctors, but also for families, and also with kind of past connections where we've done referrals in the past. So we're happy to take those calls and see what we can do to make the connections.
Great, thank you.
I think in general, the university hospitals, if there's one near where you live, are your best bet. Those are likely to be the most up-to-date group of doctors with the largest experience taking care of Kawasaki disease patients. And so in the absence of specific information, I think that's a pretty good rule to follow.
Yeah, exactly. So a major medical center, a major pediatric hospital close by is usually where we end up referring people to, unless we have someone that we know that's in that area that specializes in KD. For Dr. Dummer, there's a question about the current state of DOACs, like apixaban. Can you talk about the current state of using something like apixaban when it comes to managing blood clots for patients with giant aneurysms?
Yeah, sure. So we have a lot more information now in the pediatric population about DOACs, in particular, apixaban, rivaroxaban, they tend to be, and edoxaban, really. So they've all been studied, they're safe. We prefer using apixaban for our patients with giant aneurysms. It's a much better medication than Coumadin or warfarin, which is what used to be used by many centers and around the world, because it's cheap and things like that, but it's a very bad medication in terms of maintaining the level of anticoagulation that these patients need. So we do not use Coumadin or warfarin. We use apixaban twice a day. We've had very good success with both compliance of that medication and also not a lot of bleeding complications. I mean, anybody has a risk of kind of nosebleeds and things like that, but I have to say I've been fairly impressed with the ease of both administration and maintaining good levels of DOAC. So in all of our giant aneurysm patients, they are all on DOACs, for the exception of, I'm just going to say, the tiny babies and such sometimes leave the hospital on Lovenox twice a day, which is an injection, simply because for a long period of time, that's what we were most comfortable with. But actually now, even in those patients, there are centers that are moving towards starting DOACs in the hospital. So they are a very good medication. We do use them, and they seem to be quite effective and safe.
Thank
I
you.
don't know if anybody else has anything to say about them. But.
Yeah, and I think that's great. So there's a question that has to do with the long-term use of aspirin and any side effects that we've seen. This question was regarding kidney disease. And I can say that we follow several patients who are on long-term use of aspirin, and we have not seen any long-term side effects, gratefully. So none that we know of within our population that we've taken care of. So
I
let me
think
keep.
there's another part maybe to that question as well, which was about long-term follow-up. That's going to be addressed by Dr. Bhatt in the next segment, but I really urge that particular parent who reached out to us to make sure that your daughter does get a CT calcium score. So stay tuned. You're going to be hearing about that. And it sounds as though the follow-up that she has right now is not what we would consider to be standard of care, and that needs to be fixed. So again, adults with changes from their Kawasaki disease in childhood need specialized care, and that's going to be addressed in the second half of our presentations. So stay tuned.
Great, thank you. So there's a question, Dr. Burns, about cell-free RNA and if it's been evaluated in any other kinds of illnesses, whether viral illnesses, prior, compared to prior illness, COVID, maybe some of the work that Ewan Devlamic's group is doing. You can mention that. You can chime in.
Sure. So Connor Loy, who was a graduate student in the Cornell lab and now has graduated. So Dr. Loy had a paper that was published that you can access online in the Proceedings of the National Academy of Sciences, PNAS. That publication outlined comparisons among viral infected children, bacteria infected children, Kawasaki disease children, and children with the multisystem inflammatory syndrome, and children are MISC, the complication of COVID. And yes, that group of patients is who we're comparing with Kawasaki disease. So it's not a question of how much cell-free RNA is there. It's a question of which molecules are there. So which specific transcripts coming from which specific gene. That tells us about which cells were blowing up and contributing their cell-free RNA to the circulation. And there is a giant set of febrile controls from our wonderful emergency department that is being used in the research that we're doing to create the diagnostic tests. So lots and lots and lots of information about cell-free RNA and what the patterns look like in many different conditions.
Great, thank you. Dr. Doomer, there's a question about follow-up. So it's a child who was diagnosed with KD a few months ago at age 6, developed coronary, what's written here is coronary artery dilation, but there's a Z-score maybe between 5 to 10 in the first few days of diagnosis. Within a week, they were treated with IVIG and steroids. Within a week, the Z-scores seemed to normalize on 2 subsequent echoes. They're not going to be seen for another year in cardiology. So the question is about follow-up, and if there should be a follow-up echo done sooner. So basically that initial Z-score is 5 to 10, and then 2 subsequent echoes that seem to show a regression of the aneurysms that were there.
Mhm. So, it's kind of like Dr. Tremoulet has alluded to, there's some art to all of this, but there are guidelines or statement papers that suggest what the interval follow-up should be for different patients. So for your child, that would be an AHA risk level of 4. So patients who have had Z-scores between +5 and +10 fall into risk category 4 out of 5. So if you have Z-scores greater than 10, you're in a 5 category. So when you have a risk level of 4, there are recommendations for how to follow those patients. Your particular child has remodeled completely based on that information, but they still are a risk level 4 because at some point in time they had that level or that degree of dilation. There are recommendations for being seen in clinic, I believe, every 1 to 2 years in that situation. I don't know how young your child is. We tend to see patients more frequently when they're younger. We tend to space it out a little bit more when they're older. So they should be seen, I like that, in a year. The recommendation for doing 2-dimensional transthoracic echo after your vessels have remodeled is basically that it's not necessarily necessary, but I'll say that we do tend to do echocardiograms in follow-up just at a baseline, not necessarily to remeasure the coronary arteries, but to look at the function, and people feel very reassured about those sorts of things. But the main thing is that once your child is old enough to exercise, that there is an indication here for ischemia testing. And ischemia testing can be done in a number of different ways. It's institutional based on what resources you have and what you believe in. We do stress echocardiography. So as soon as your child was old enough to reach the bicycle pedals, which tends to be around 7, 8 years of age, we would be following your child with stress echo every 1 to 2 years. And that's because what we care about most is, now that the vessels have remodeled, we want to make sure that they can behave in a manner that is good enough to bring extra blood flow to the heart muscle when we're stressing the heart. So we look at stress echo. Some facilities look at MRI stress perfusion, which is a larger undertaking, but a very sensitive test. And very rarely do institutions do like nuclear medicine scans, which we don't necessarily do because there's a very high dose of radiation. So the main thing is that your child needs to have ischemia testing going forward.
Great. Yes, that's perfect. Thank you. And that brings us into the break. Right before we all break off, I'm going to put in a quick plug for something here. All right, so thank you to all of our speakers in the first half of our session here. You may have remembered this from a year ago. We're doing it again. We would love you to be involved with our research. One of the tools that we did not discuss today is the development of a photo app, which uses pictures from children with and without Kawasaki disease, getting to the point of controls that Dr. Burns mentioned. So what I'm going to leave up here for the duration of our break, which will be about 5 minutes, is if you have pictures of your child at the time that they had KD, and are interested and willing to share those for the purpose of research, there is a QR code here developed by the KD Foundation. There's a quick little consent form that you have to sign, and then you can upload photos. If you did it last year, no need to re-upload, but if you didn't get a chance last time, we would really be very appreciative. So with that, I will bring us into the break for about 5 minutes. We will come back at 10:45 for the rest of our fantastic program. So we will see you shortly. Thank you. All right, everybody, welcome back. Hopefully everybody can see my screen in full presentation mode. It's a pleasure to be with you. I'm Dr. Audrey Tremoulet, Associate Director of our Kawasaki Disease Research Center. And I'm going to share with you some work that we've done over the last year about infographics for medications that are used to treat children with Kawasaki disease. So our families will remember this environment when your child is diagnosed with KD. You're worried, you're stressed, you're exhausted. And in the midst of those incredibly warranted emotions, you're getting a lot of information from the physicians, from the nursing staff, from maybe multiple providers. It's probably confusing information and how it's presented many times. And you're asked to really take in a lot. And we know this is happening to our families, and we wanted to see how we could mediate this situation for our families, specifically related to the treatments that kids are receiving, so that our families would have a better understanding about the medications they're receiving. So while visual aids are recommended to improve health communication, there's really very few specific resources for medications that are being given to children with acute conditions in the hospital. So it may be that when you go home, you get a huge printout with the after visit summary. If you've been in the emergency room or in the urgent care in a pediatrician's office, you may get a whole thing printed out. But in terms of knowing what your child's being treated for at the time of treatment, there's really nothing that gets handed to families as far as we were aware. Maybe you're somewhere that was doing something, but we weren't doing it at our center, and we realized there was a lot of confusion that was happening with the medication treatment. So we went ahead and used an incredible resource, which is the students that are volunteering at our research center, at our Kawasaki Disease Research Center at the University of California in San Diego and Rady Children's Hospital. And here's just part of the group of the army of amazing folks. Most are undergraduates that have found us. Some have themselves had KD, others have had siblings, others have heard about Kawasaki disease, some never have, but found our group to be an exciting group to be part of. And we asked them to work with us to develop these one-page infographics written at the 8th grade level, as is usually what we try to aim for our consent forms, to have some pictures for those of us like myself that are visually minded and how we want to learn about things, and to really focus on the different parts of the treatment. So then we went ahead and we took these infographics and we brought them to the bedside. And it's been a little bit, probably between 6 to 9 months that we've been bringing these to our families as they've been developed, to be able to share with them something that they can hold on to, that when things are a little quieter, that they'll have some information, that it allows them to read it on their own and then ask us questions while they're in the hospital. So here I'm going to share just a couple of the infographics that we have, one on aspirin, one on IVIG, just to highlight a couple sections of these particular visual aids. So the first is the why. We think it's really important that families not only, in this moment, that we say, we're going to treat your child with aspirin, but really, why are we treating your child with aspirin? Why are we choosing to treat your child with IVIG? If IVIG is not sufficient and your child's refractory or has coronary artery abnormalities, as per the American Heart Association statement, your child should get something else. So what else are they going to get, and why is that treatment being chosen? Then there's also the question about safety. This is so important for all of us to understand and to be really have the same understanding. The treatments that are being used in KD, as we know, are safe, but also may have some risks associated for some of the treatments. And we want to make sure that, patients understand when they're being treated with aspirin that there may be some increased bruising, there could be some nosebleeds. And so that's a real important part of it for us, for all of you as our families, to really understand the safety evaluations that have been done for the treatments that are being used. And then we wanted to also include some visual representation, some visual aids, and to be able to explain. So here with aspirin, just as an example, we show the platelets, which are the sticky cells coming together, and that can sometimes form some blood clots. But then without aspirin, those sticky cells may not work as well. So maybe this is why there's increased bruising, or if you get a little scratch, it may just bleed just a little tad bit longer. And we want families to be able to understand what to look out for and how that relates to how the medication works, why we're using it in Kawasaki disease, and really the safety profile. And you can see that we've done that as well for IVIG. So we went ahead and we made a list of most of the medications that we use, some commonly, some less commonly. So in the category of decreasing inflammation, not only have we developed one for IVIG, also for infliximab, also known as Remicade. The Dr. Dummer spoke about steroids, got a little asterisk because we're currently finishing up the development of that one. And then some less commonly used ones like cyclosporin, anakinra, and naproxen, which are given the first two for inflammation. The last one we sometimes give to kids that may have some joint pain associated with Kawasaki disease. Then also medicines to inhibit platelets, which I already showed you. There are the sticky cells that can help us form clots, or even blood thinners. We talked about aspirin, clopidogrel, known as Plavix. Someone asked about apixaban for the direct oral anticoagulants, and enoxaparin, also known as Lovenox. And then there may be medicines that are given to your child to heal the lining of the blood vessels. I've shared with you in years past the work that our team has done on evaluating atorvastatin, also known as Lipitor, which is a common medication. It's given for cholesterol lowering, but that's not why we're giving it to our patients. We're giving it because one of the amazing things of the statin family is that it heals the wall of blood vessels. And we think that it may be very helpful in those children that have very large aneurysms. And so we want to educate our families about why that is given there. So all of our infographics are currently on our website. We have them available currently in English and in Spanish. A couple are still in production, but we're putting those up as they become available. It's important for you guys to know that that resource is available to all of you, and we're trying to get the word out to others about these infographics and their availability. So how are we doing that? The infographics, as I mentioned, are now on our Kawasaki Disease Research Center webpage, and I've got the QR code there. We're also putting up those infographics on ikds.org. Some of you may be familiar with this website that was launched last year with the International Kawasaki Disease Symposium that was held in Montreal. That website is still active and has a resource page on it. So I would invite you to go to that resource page where you'll find things like these infographics. It also lists any upcoming meetings that are happening related to Kawasaki disease. So if you see one in your area and it's not posted there, please send a message to ikds.org. There's a way to do that at the top of the website. But you can find the infographics also listed there. So next steps, there's still lots of work to do. We have to get this published. So we want our providers to know, and to do that, one of the ways we do that is to publish things in the peer-reviewed journal. So we're trying to figure out a way to do that, whether it's through MedEd Portal or through a different publication route if that doesn't work out. And so we want to get this out into the medical literature. We're also working closely with the Kawasaki Disease Foundation and working with them to get these posted on their website as well, so that it becomes a resource for all families that may join us. This is also a moment for me to put a plug in that I know that we have people that are listening to us online today that may be involved in other foundations around the globe. We're blessed to have many parent foundations throughout the world. And if you are interested in hosting this on your website, please reach out to us. We also would love to be able to share the Canva version of these infographics. If you are interested in having it translated into your local language that would be most useful for your providers and your families. These are, we made them, but we don't own them in perpetuity for us just to have. We want them to get out to the world. So please reach out to us. So we want to host this on more websites and translate into more languages. KD research at health.ucsd.edu is a way to really reach us and to let us know that you would like to join us in this effort. And if you feel that there's a medication for the treatment of Kawasaki disease that we're not including here, please let us know. And we'd be happy to have that done by a different site, or we can see how we can take that on as a task. So again, KD research at health.ucsd.edu to host or to translate them infographics. So a huge thank you to our group. This is absolutely a team effort. I'm just up here representing what's been done, and the heavy lifting and has really been done, as you'll see here on the bottom, by these students here, which will be included in our publication to, of course, give them credit in the peer-reviewed literature as well. So I'm very grateful to all of you for your attention and your time this morning. With that, I will stop sharing for me, and I will go ahead and introduce the next speaker. So I'm pleased to be able to introduce Professor Jennifer Burney, who is joining us from Stanford University, where she serves as a climate scientist. She's been helping us for years with our climate work here at the Kawasaki Disease Research Center, and we're pleased to have her join us again today to share an update about the work that's being done with understanding where Kawasaki disease may be coming from. So I will hand it over to you, Dr. Burney.
Thank you so much. And thank you to everyone for joining today. Let me just make sure I can pull this up correctly. Does that look okay? Okay, great. Well, thanks to everyone for joining today. And I want to begin, as I always do, by saying it's such a treat to get to be part of this team, trying to understand what causes Kawasaki disease. I'm really fortunate to, as a non-medical person, to be able to work with these incredible caregivers and scientists. And I'm also really grateful to be part of such a wonderful community. I know this is a club that no parent would choose to be in, but I'm so grateful to everyone for participating in this quest, this research together to try to understand what causes KD and to figure out how to best take care of and protect all of our children. So thank you, and thank you for being here. Today, I want to talk about some work that our team is doing on the environmental side of this question. As all of you are probably aware, there have been a number of studies over the years that show relationships between Kawasaki disease and various environmental phenomena like weather, wind speed, pollution. And so we have decided over the past year or so to take a really deep dive back into this question. There are a number of reasons why we think this is the case, right? We all want to know what causes KD, but why would we look towards the environment? There are a lot of reasons from the biological and epidemiological studies that have been done that help us think about this. And they suggest that Kawasaki disease is probably caused by an agent or agents that are breathed in through the nose or mouth and trigger the cascade of symptoms. So if it's something suspended in the air that we're breathing in, well, then people like I and our team can start to help by looking at where the air is coming from and what's in the air when people are getting sick. I want to start with this graph, which is from a paper that came out, a study that was published last year by many of the team here. And what this shows is over time, the relative rates of Kawasaki disease in Japan for different age groups of children. So you can see that this runs from 1970 up near 2020 with the pandemic, and you can see that steep drop off in the pandemic that we know occurred all over the world. But what I want to draw your eye to is that really since about 2000, this green line are the youngest patients. These are the babies in Japan under 6 months of age. And these dark blue, gray, and blue lines are the older children, 2, 3, 4, 5 years old. What you can see is that the incidence among babies has gone up, but mildly compared to the incidence for the older children. And there's really just nothing in the world that looks like this in terms of diseases. This is especially interesting because in Japan, there's a declining birth rate. So this means that it's not just that there are more susceptible children, say, being exposed to the same things. It's that whatever is causing it has to be going up. And so this also makes us very intrigued by what is blowing in the wind. So I'm going to talk a little bit about these trends that we see, but I'm also going to refer to a few other environmental phenomena that point us in this direction. The second is that Kawasaki disease has a very distinct and regular seasonality. So when we think about other illnesses of childhood, like every respiratory illness that a kid could get, they often have a seasonality, but it's a little bit looser. We know it's higher in the winter, lower in the summer, or some peak in the summer and are lower in the winter. But the onset is not necessarily like a clock every year. That's not the case for Kawasaki disease, right? Kawasaki disease has a very systematic, regular seasonality. And that also is something that points us to the environment. The third feature of Kawasaki disease that makes us think about the environment is the fact that it occurs also in bursts. So in addition to these trends, and in addition to the very regular seasonality, we know that Kawasaki also comes in clusters of cases. And this is something that clinicians around the world have talked about, that sometimes it feels like they're always overwhelmed. When there's Kawasaki disease, there's usually a lot of Kawasaki disease. So 3 features that all point towards environmental associations. What we've tried to do over the past year or so, but really what our team aims to do, is to use information about who gets Kawasaki disease, where they are, and when they get it. And most recently, we've been taking that information in Japan and modeling the weather really backwards in time. Think about running the weather backwards for those days and locations to see if there are patterns that are associated with KD incidents. So we're really looking at where children get sick and then using weather models to see where the air was coming from when those children got sick. So I'll show you a little bit about what that looks like. We've been using 5 regions in Japan because Japan spans a very big environmental range. And so there's a lot of variation that helps us make sure that what we're seeing isn't spurious. We can see it happening in many places. We believe it more. And we've used this decade before the pandemic interfered with the patterns. We've used this decade prior to the pandemic to study these wind patterns. So I'm going to show you some images, figures from the Tokyo data, but we've really used all 5 of these spots. If we look over on the left, this is what it looks like to run one of these weather models backwards. We take, for example, Tokyo, and for each day where a child got Kawasaki disease, we launch a bunch of imaginary particles into the atmosphere and run the weather backwards to see where those particles would have originated. So here's one example of launching all those particles into a weather model. But then we do that over the course of the whole day, because of course wind patterns change over the day. So over on the right, you can see now each line is the path of one of these particles, and we can do this over a whole day and see really how the weather swings around a little bit, but it's still coming kind of from passing over Korea and over into Tokyo. So we do this not only for a few times a day, but really for every day of the year. And then we can end up with patterns like this. So we can see, for example, over Tokyo, where the air was most likely to be coming from on any day of the year, but really here I'm showing you the monthly averages. And red means it's more likely to be there. And if there's no color shown, that means the air really wasn't coming from there. So you can see that this does move around over the course of the year. And so we have these very detailed patterns now of where the air is coming from on any day. And we can match that to when children were ill. Let me show you a little bit about how we do that. So we take those patterns, and while they're lovely movies, we try to distill that information into a few numbers that we can use for these analyses. So one is the distance, how far away, say 1 day before the child fell ill, how far away was that air? And the other is where directionally was it coming from? So we take those statistics, and now I'm going to show you we match it to, again, this decade of data between 2010 and 2019 in Japan, where we have all this very dynamic movement that's different across age groups. And we're going to look again at the year-to-year patterns, the seasonal patterns, and these shorter bursts. So let me actually point back here for 1 minute. You can see over here in 2016 to 2017, especially for the older kids in Japan, there was this very pronounced dip, right? Almost half the size of the pandemic drop-off in that year. Very interesting, and we want to know what we think causes it, right? Especially against this big trend upward. What would cause this dip, and is there an environmental association? So if we look at really what the circulation patterns look like, what I want to draw your eye to is that the left panel here is before that dip. The right panel over here is after that dip, and the middle panel is during that dip. And this region that's outlined in red is what we would call anomalous. It is not the regular pattern. It is something that looked very different over that main Kawasaki disease season. And as you can see, that anomalous region is sitting right over Japan. So there indeed was something very different about the weather during that time period where we saw that dip. Now that's just 1 year compared to the average, but we'll look also at the seasons. So here again, I'm showing you a graph. It's a little bit noisy, but I'll walk you through it. This is information from Tokyo, and what it is showing is what the regular seasonal cycle of Kawasaki disease looks like over the course of the year. So the Kawasaki disease cases, that's the black line. So it's showing we have this peak at the beginning of the year, sort of slopes down. As you know, the low point is usually September, October. That's why we have our parent conference in this time period. And then we ramp back up towards the end of the year, back towards the peak. One thing that we saw when we modeled this information about all of the cases in Tokyo over that decade was that every year, and this holds for other regions as well, there is a direction change in the wind that precedes the rise of Kawasaki disease cases back up towards the annual peak. And that happens, this is showing you the average. So we have air is coming from further south at the low point, and it swings back up to be coming from the west and more the northwest for the peak. Also, it starts coming from further away. So this is again indicative of maybe long run transport of something in the air being associated with the rise again of Kawasaki disease. Now, as you can tell, there's a lot of movement, right? There's rain, there's storms, there's other things that happen in here. But this association of the change in direction and the change of where the wind's coming from preceding the rise in Kawasaki disease, that happens year on year. So years where it happens earlier, the rise is a little earlier. And that also holds across the country from different locations. So while it happens at slightly different times in different locations, it is very regular. So this is, again, quite intriguing in terms of an association with the environment. All right, the last piece I'll talk about, we talked about the year-to-year changes. This is now the seasonal cycle. We also looked at those bursts, right? So this idea that when you get Kawasaki disease, it's often in clusters of cases. We also looked at these clusters in Japan. So again, I'm going to show you some information from Tokyo, and I'll walk you through this. So we took the time series of Kawasaki disease cases from Tokyo, and we delineated cases that occurred in bursts, meaning when it was a much higher density, a much higher group of cases, much more, a higher number of cases in a period of time of Kawasaki disease than kind of the normal rate of Kawasaki disease for that time of year. We delineated those bursts, and we looked at the wind conditions that were around the time of those bursts and compared them to average. We also looked for comparison at all the other cases that don't occur in bursts, that are just sort of at the normal rate for that time of year in Tokyo. So let me walk you through what we found. I'll start over here on the left. If we look at those non-burst cases, just sort of the regular flow of Kawasaki disease, those show no difference from average wind conditions for that time of year. So the wind on the Kawasaki disease days looks kind of like the wind on regular days for that time of year. If we then turn to those bursts of Kawasaki disease, there's a very different story. A week before a burst, the weather looks normal, the air looks normal. There is no difference between where the wind is coming from and how fast it's going or how far away it was the day before than regular conditions. So this is this line here. It overlaps the average. So a week before, everything looks normal. On average, a few days, 3 days before a burst starts, we actually see a change in the wind. You see actually like a drop in wind speed or wind distance for the 3 days before. And then when a burst starts for the first 3 days or 7 days, you actually see a rapid switch in the other direction. So faster winds coming from further away. And these are all very strongly statistically significant for most regions across Japan. So in conclusion, we have used these, we call them back trajectory studies, but again, we think about it as running the weather backwards and seeing where the air is from. These studies have suggested that the atmospheric conditions and various associations and variations in those conditions, are in fact significantly associated with Kawasaki disease over a few different time scales, year to year, the seasonal cycle, and in those weekly shorter bursts. So this is more evidence that atmospheric conditions are driving some of what is exposing especially older children to Kawasaki disease triggers. So we still don't know the what, but we're learning more about where to look every year. And as always, I hope to be back next year and telling you that we've found the answer. Thanks.
Thank you so much, Jen. That was a deep dive into climate science, but I think very important for finding the answer here. So it's my pleasure to introduce Dr. Jiken Bhatt, who's an adult cardiologist at the San Diego Cardiac Center, and a film producer, Mr. Kieth Solomon. They're going to share the next segment together, and I will let them take it away. Thank
Sounds
you.
good. Thank you, Jane.
Hi there.
Thank you so much. Keith's on too. Perfect. I'll start this, and then we'll have kind of Kieth give his story at the end, if that's okay. This is my first time at this meeting, so thank you for the opportunity to kind of talk for a couple of minutes. As Jane mentioned, I'm an adult cardiologist. I've been with the San Diego Cardiac Center for about 6 years now, and helped take over what Dr. John Gordon had started here with our adult KD population. And I'll share my slides here. Let me see, make sure it works. Can everyone see that okay?
Yes.
I assume that's yes. All right. So, adult Kawasaki disease, or Kawasaki disease in adults who've survived Kawasaki disease in childhood, kind of unique set of problems, not really the same as what we see as adult cardiologists typically, and definitely different than what our pediatric colleagues are seeing at Rady's and with your children. So I think it's important to note with our cardiologists that we rarely see Kawasaki disease as adult cardiologists. In fellowship, I never saw a case. You read about it in textbooks, but it really wasn't until I came here to this cardiac center that I saw my first case, and now I've seen over 50 cases of patients who've survived Kawasaki disease in childhood. And so it is important to note when you go to see a cardiologist that they may not have familiarity with the disease outside of what they remember from medical school. And a lot of that's changed over the years. Many of the pediatric cases of Kawasaki disease went undiagnosed, depending on where our patients grew up, or they maybe thought their aneurysms or whatever long-term impact they had resolved, and it was felt that they didn't need any cardiology follow-up. There's also some patients who kind of, when they get in their teenage and young adolescence, kind of think that they've outgrown it and don't necessarily follow up with the adult team. And I think we see these patients at kind of different stages along their livelihoods. The other thing we need to keep in mind as adult cardiologists is our patients will still have the same traditional risk factors, whether it's hypertension, diabetes, high cholesterol, all of those things that lead to traditional coronary artery disease. So a lot of times we're not just treating them for their risk factors and their risks with their Kawasaki disease and their aneurysms, but also traditional coronary artery disease. The way our patients present to our clinic is this whole spectrum of conditions. A lot of our patients, thanks to the team here, were treated in childhood. They knew about their KD early on. They got treated adequately and either didn't respond and had persistent aneurysms, or they actually had aneurysms that healed. And a lot of these patients will come into our office. Maybe they were discharged from their pediatric cardiologist saying that everything was okay, but they have some symptoms they're concerned about, and with their history of with Kawasaki disease, want to get evaluated. And then there's those patients who didn't know that they had Kawasaki in childhood, and this is where Kieth will kind of give his story. But this may have been found incidentally when they got a CT scan for either for symptoms or lack of symptoms and just for evaluation. A lot of our patients these days are getting calcium scores, which are non-contrast CT scans just to look for plaque. And when that score comes back very elevated, there's some concerns that are raised and they end up in our office. Or maybe they had symptoms, they had chest pain, and they ended up in the cath lab getting what's called a coronary angiogram to look for heart blockages. And instead of finding what we traditionally expect to find, we find these large aneurysms. Or rarely we'll have patients that come in with a heart attack. And again, they'll come in emergently to the hospital. We'll take them to the cath lab to look at their arteries. And we find, again, not what we expect to find, which is a blockage due to plaque, but actually perhaps clot or aneurysms that are affecting blood flow to their heart muscle. Our treatment in the adult population is similar, kind of a carryover from what we were doing with our pediatric population. As we've talked about earlier today, aspirin's a big part of this. Our patients who have persistent aneurysms that are large, greater than 6 to 8 millimeters, we stop kind of using Z-scores as we get into the adult population. We will frequently put on oral anticoagulation or blood thinners. We traditionally used Coumadin. Nowadays, at least in San Diego, we've kind of transitioned patients to blood thinners that are a little easier to use, like Apixaban or Eliquis, which don't require as frequent monitoring of blood levels and have a kind of a sustained effect and don't have the limitations with diet that Coumadin used to have. We continue our statins in our patients. Again, here we're looking for two benefits. One is to lower cholesterol, but the second one is to reduce that inflammation like we talked about earlier. Again, patients who've had Kawasaki disease, who have aneurysms, cannot only have issues with their aneurysms, but have traditional risk factors, again, like diabetes, high cholesterol. We've got to make sure we're treating both of those conditions. Rarely in our adult population, we do have to do what's called revascularization or opening up of arteries and getting better blood flow down to the heart. This can be with bypass grafting or rarely with stenting. But this really should be reserved for patients who are having a lot of symptoms with their aneurysms, who really aren't getting enough blood through those aneurysms and down into the heart muscle itself. How do we look for this? So we'll monitor our patients annually with stress echocardiograms, basically putting our patients on a treadmill and looking at their heart function before and after to make sure we're getting enough blood flow to the heart. And then coronary CTAs, as has been discussed, I think we're using more and more to really look at the size of the aneurysms. Is there clot in the aneurysms? Is there flow getting past the aneurysm? And that we'll do periodically, and that'll vary patient to patient on how often we do that. This is the adult Kawasaki team that we have here between Rady's and the San Diego Cardiac Center. I think Jane can talk to you about that more, but we do have the adult KD study where we have one of the largest groups of patients with Kawasaki disease who have persistent aneurysms as adults. Some of these patients came through Rady's Children's Hospital, but more and more we're finding patients from across the city, the state, and really the country with Kawasaki disease that are coming in to see us and enrolling in the study, which is a questionnaire-based study to help follow our patients year after year and seeing how they're doing, how their families are doing, to really learn more about this rare condition. And this is a link for the website and to email our team here. So if you are interested in enrolling in the study, if you're not a part of it already, really helpful to us, and I think helpful to the future patients out there, which we know is a growing population. I also wanted to give a quick link to the San Diego Cardiac Center website for patients who are looking for more information into adulthood. And then Kieth will talk about this briefly, is also fortunately a filmmaker who helped put together a great video to help adult cardiologists kind of learn more about KD and what they can do and what they should be doing for their patients. And there's an upcoming film for our patients for more information for them. And we'll share that with you once that's completed. Kieth, you want to take it away?
Turning back on my audio. Okay, I can see my volume going up and down. I can just see the your slides still on there. So I don't know if they see me.
We hear you great. If you can stop sharing. And also,
Yeah,
Jiken, we love your children, but we're all hearing them because of the way your mic is set up. So we heard them through your whole presentation. We love children, but maybe you could mute at this point and come back for questions.
Yes, we'll do. Sorry.
That's right.
Okay.
And stop sharing your slides. We'll get that off.
You're good now?
No, it's still sharing.
But I like the background. It's very peaceful.
Well, Keith, take it away. We're happy to
All right.
have you
Anyway,
here and people can hear you
So
well.
about a year ago, I'm 57 now. I've been I thought in pretty good health most of my life. And let me just make this so I can see myself bigger. Gallery. Well, that didn't work. Anyway, so about a year ago, a friend of mine thought he was having a heart attack and saw a cardiologist, and he's like, you should get a CT scan. And he did. Turns out he was having a stress attack. But he told me, hey, you should get this CT scan. It's inexpensive and you can check under the hood and see what your calcium score is. And I'd been worried about cholesterol because my grandfather had a heart attack and myocardial infarctions, and my mother was just hypervigilant about it. I've been on a statin for about 20 years, just preventatively. I've been monitoring my cholesterol religiously. I was really good numbers. Anyway, so I decided I'd take the test just to check under the hood. And to my shock and horror, I didn't get the 0 or 7 or 8 that I expected, but I got like 1158, which anything over 400 apparently is dangerous. So I was freaked out. And when I eventually found a cardiologist, I walked in and I said, hey, so what's my best case scenario? And he's like, well, your best case scenario is these aren't your test results. And I'm like, thank you. And I started to freak out. So fortunately, he had been to some symposiums that Dr. Gordon had given about Kawasaki, or someone in his practice. It was like 24 cardiologists in his practice had. And I guess he had asked around, and one of them mentioned Kawasaki disease as a possible culprit. And he told me, well, listen, fortunately, Dr. Jane Burns is one of the world's experts, and she's in San Diego. I live in LA, so it's pretty close. You should definitely see her if you can, and then see a geneticist. And about 2 months later, I finally got in to see Jane, which wasn't easy because every time I called, she's a pediatrician, as you know. So every time I called, they're like, sir, this is a children's hospital. Anyway, I finally got in touch with her, and she told me it was absolutely 100% Kawasaki disease. And she walked me through it and reassured me about what it was. And on the same day, I saw Dr. Bhatt because they're very close to each other. And he reassured me by telling me about, listen, the only thing that's different about this is the information. You've had this your whole life, all through college and all those sports you did. It's just information that's different. And when you were young, your body was relatively resilient, and it was able to develop collaterals so that your circulatory system was able to compensate. And you're really fortunate that you were on a statin because, 20 years ago, everyone thought the statins was about lowering, the cholesterol, but it seems like one of the main benefits we're now learning is, if I understand it correctly, is the anti-inflammatory properties of statins, which was hugely beneficial for me, who has 2 large, giant aneurysms. Anyway, so he put me on all the drugs that he mentioned there, aspirin and DOAC or Eliquis and things like that. And when I saw Jane, my story is not in the right order here. She was telling me how lucky I was that I had seen somebody who knew about Kawasaki's, because many patients see somebody who are not familiar with Kawasaki and see all these signs and treat them like standard cardiac patients, which is very dangerous often for KD's adult survivors. And she said she was just one voice, and, I'm a video maker, and I'm like, I can help. And it was very therapeutic for me to help make that video so I could learn a lot about it and come to terms with it and get to know Jane and Jiken in the process. And so hopefully now we can educate more cardiologists. Our next video is one for adult Kawasaki patients like myself. I really wanted to create something that would give the information and comfort that I received when I first saw Jane and Jiken, because I can tell you, after seeing a regular cardiologist, I was pretty freaked out. So there wasn't a lot of reassurance there, and it was good to get that information. And now we're doing that. And down the way, we hope to make a redo of the the video for Kawasaki, parents of kids with Kawasaki, because it's a little dated. But we're trying to raise funds for that, but that's down the line. So that's my story. Mic drop.
Thank you so much for sharing that story. I hope that this is a very positive note for people out there. Tell the audience, if you would, Kieth, about your diagnosis in childhood.
Oh, I didn't mention that. Okay, sorry. When I was, fortunately, as it happens, my mother was friends with my pediatrician. So when he retired, he gave her all his notes on me, and my mother doesn't throw things away. And of course, when she was cleaning house about 5 years ago, she just mailed me a box with all my stuff. And it was this packet, which I never looked at. So when I met with Jane, and she said that you probably had some illness. Actually, it was before I met Jane, but I was on the phone with Jane when she called me before I saw her, and she said you probably had some illness that presented similar to something like scarlet fever, high fever, conjunctivitis, swelling, all that type of stuff. And so you should look through your records if you have them. And so I went through these records, which had never been opened since I was like 13. And I couldn't make any sense of it because doctors write in some very Sanskrit. But my wife is a doctor, she could read it. Anyway, so we went through it, and we actually found, when I was 2.5 years old, the actual thing, the ailment, which mirrored scarlet fever. And when I brought it into Jane, she was super excited about it. And then if you watch that link to the video, you'll see the card, the doctor's handwriting on the card in the video.
Right. So that's a nice segue, Kieth, into one of the questions in the chat, which was, what are the diseases that get confused with Kawasaki disease? So scarlet fever can be one of them. So thank you so much. Stay on if you can. You can mute yourself, but there may be questions for you in the chat. And now we'll move to Amy Weeks and have you share your.
Thank you so much, Dr. Burns, and thanks everybody for having me. Thank you, Kieth, for sharing your story. As the mom of a young man who's going to be transitioning to adult care in the near future, I appreciate all of your efforts. I also want to say congratulations to the Kawasaki Disease Foundation on 25 years of amazing work supporting families, and appreciate you all hosting us today. We're really, really grateful to everyone who supported Kawasaki disease, the Kawasaki Disease Research Center's team's efforts to understand Kawasaki disease. And so much of the amazing work you're hearing about today would not be possible without Philanthropy. We are excited to share a new match opportunity from the Gordon and Marilyn Macklin Foundation. Their most recent grant to Rady Children's is matching all gifts to 2 important projects focused on improving the diagnosis of Kawasaki disease. You've heard about them today, the Kawasaki Match project being led by Dr. Gardiner and the CFRNA project being led by Dr. Burns. More details are available on the webpage that can be accessed through the QR code here. And we really hope you'll consider helping us meet the match by making a donation online or by reaching out to me by email, which is here on the slide, for other options. So once again, thank you so much to all of you for supporting this really important work. And we appreciate you being with us today. And now I'll turn.
Excellent, and thank you. Just a little slow with the fingers this morning. We're now going to open it up for our second Q&A session. And we want to make sure that we try to get to everybody, but there are now a lot of them here. So I have questions for Kirsten, Jiken, Audrey, and myself. So if you can get ready to answer some questions. Jiken, a question about long-term follow-up. Why is a calcium score useful?
Yeah, so calcium scoring is really helpful for us because it helps find these patients in a lot of ways. So for patients who don't have a history of Kawasaki disease, as in Kieth's case, a lot of times the first time we find them is we get a calcium score that the number just comes astronomically high. And we typically in the adult population look for calcium scores because we're trying to find patients if their cholesterols are high, if they have diabetes, on how well we're doing with managing their risk factors for heart disease. And it's a way of screening for that. But in our KD patients, it's a little bit different. The aneurysms cause damage to the vessels, and that damaged vessel eventually calcifies over years and decades. And we can see that even in young patients without risk factors. So a little different process, but we see that calcium develop pretty early in patients with Kawasaki disease.
Right. Kirsten, a question for you. From a mom with a 3-month-old who ended up with giant aneurysms and is now 19 months old. First, she'd like to know how often should a CT, I assume angiogram, be done? And I'll let you start there, and then there's some other questions.
Okay. So I'm sorry, I might have missed if the child had aneurysms or giant aneurysms.
Yes,
or
2
what.
giant aneurysms and is now 19 months old.
Yeah. So again, this is kind of a bit variable. There's no strict, hard and fast rules, but typically patients with giant aneurysms would likely have had a CT angiogram prior to leaving the hospital, kind of as a baseline of like, here's where we're at. And then we tend to do them again a year out from the acute Kawasaki illness. After that, the recommendations are quite wide in terms of what frequency to repeat CT scans. So if the aneurysms are persistent, then they say that you can do advanced cross-sectional imaging like every 2 to 5 years. So it really depends on, kind of how you think things are evolving, or if there's changes to, what we see by echo on function or things like that. But in general, we do 1 CT scan before they leave the hospital, a CT scan around a year out from the illness, and then after that, every 1 to 5 years.
Great. Audrey, this same patient had a question, the mom had a question about statins. This is a 19-month-old.
Yeah, so the study that we conducted on the use of atorvastatin in KD patients was for those 2 and above. So children 2 and above are the ones that we have evaluated the use of statins for giant aneurysms. That's sort of an FDA line in the sand that they draw based on what data is available in younger children. And unfortunately, those data were not available for atorvastatin. So in our patients, we've been using it in kids 2 and above. And that may be a conversation for them to have in a few months with their provider.
This mom apparently had information from somewhere that stopping dairy could be helpful in healing aneurysms. Any thought about that, Kirsten? You're muted.
Yeah, that is not something that I am familiar with. And if there was something as simple as that, then it would be amazing. So not likely to be associated with any healing properties.
Yeah. And I think that in this age of social media, we're all dealing with floods of information, some of it disinformation online. And so please, if you read about some magic wand that can make aneurysms go away, or some dietary supplement or something, please check with your cardiologist about that. We wish there were silver bullets that made the world a better place so easily, but please check with your cardiologist about those. There was also a question about gum soreness in this child and crying when she brushes her teeth and bleeding. I don't think we know what medication she's currently on, but presumably she's on systemic anticoagulation, we hope, hopefully with a DOAC, and hopefully with aspirin as well. Any thoughts about that, Dr. Dummer? Bleeding gums.
Well, certainly bleeding in general when patients are on anticoagulation and antiplatelets is always something we talk about. I'll say that gum bleeding with brushing teeth and nosebleeds are probably the most frequent things that we hear about in the pediatric population, although again, pretty rare. So it's possible that if your child is having some bleeding, that maybe that, further has some irritation of the gums, and that's why she might be sore, but not, gum soreness in and of itself in the absence of bleeding is not something that we've heard a lot about in our patients on those medications.
So while we've got you, another question about myocardial infarctions. That's the term for heart attack. A 14-year-old who's had a heart attack after Kawasaki disease, and the parents want to know what the risk of a second heart attack might be.
Yeah, so that's always hard to predict. I mean, the highest risk of ischemia or infarction happening tends to be in the first 2 years, particularly obviously in the subacute phase after the acute illness, because your body's still inflamed and it's probably making some clot. And so I would presume that your child had aneurysms and then had clot, and that's what was the etiology of the infarction. As long as he's being properly anticoagulated, and that means with medication and levels of medication that are adequate for true anticoagulation, and on antiplatelet therapy, the combination of those two should hopefully prevent further clot. But there are times when the clot burden in the vessel is so large that we've had patients admitted for, I say clot busting medications, but there are ways that you can use some medications in the acute myocardial infarction that can bust up the clots and hopefully prevent further clot burden. But if he's being adequately anticoagulated on antiplatelets, the hope is that he doesn't have any further myocardial infarction.
And there was a question about whether or not you measure apixaban levels.
That's a really good question. So we do. Once you become an adult, there are just standard dosing guidelines. So the majority of adult-sized patients are on 5 milligrams twice a day of Eliquis. If the patients have a weight greater than, I think it's 100 kilograms or something like that, there are some patients who require 7.5 milligrams every day in the adults. So the adults are kind of standard, and you usually have adequate anticoagulation. With the children, because we are cutting up pills and using smaller doses of it, we are quite careful with following what we call apixaban assays. So it's a way of measuring kind of the effect of the medication, and we do measure them in our patients when we first start them, and then we follow them every 6 to 12 months, particularly as the child's weight is changing and we are changing doses. So not super frequently, but I would say on average once a year in the patients who are not on standard dosing.
There is a question. There are a lot of questions. I hope we can get through all of these. There's a question about the risk levels, the American Heart Association risk levels, and how are they determined? What's the measurement that matters for what your risk level is?
Yeah, so it is based on your Z-max. So the worst echocardiogram that you had, and that's kind of how we categorize people. So if you had a Z-score of +8, but you're normal now, you're always going to be in that risk category related to +8. You don't come out of that risk category. What changes in terms of your follow-up has to do with if you've fully remodeled or if you have not fully remodeled. And obviously the patients that have fully remodeled the recommendations for follow-up are a bit more lenient, right? Like a little less frequently, maybe less ischemia testing, but not zero, and less surveillance with CT, but not zero. If you have persistent changes, then you kind of ramp all that up. So we do, like I said, we do follow patients every 3 to 6 months when they have residual giant aneurysms, and we're obviously doing more frequent ischemia testing and CT scans. So the risk categories relate to the worst that your arteries ever were. And it's really just the worst of any one artery. Doesn't matter if you have 3 giant aneurysms, 2 giant aneurysms. What matters is the worst Z-score of the worst artery at the peak of your illness.
There's a question here for that I'm going to field, which is globally, is there a cardiovascular risk for adults who had Kawasaki disease in childhood but did not have aneurysms? And what our recommendation is that you are not going to get new aneurysms as an adult, but our concern is that particularly for people who had their disease and had their echoes done before the year 2000, the pediatric sonography world at that point didn't have the super accurate transducers, just the methodology wasn't worked out as well. And we clearly have seen adults presenting with aneurysms that they didn't know they had, despite having had echoes in childhood where they were told it was normal. And because of that, there seems to be a timeline of that kind of problem that before 2000, the echoes just weren't as sensitive. They weren't as detailed. They weren't necessarily as good. And perhaps if you had your echocardiograms done at a center that wasn't very experienced or expert in imaging the coronary arteries, it doesn't hurt to get a CT calcium score. And then there was a question about as a screening test as an adult. But for sure, if you had your Kawasaki disease in the 1980s or 1990s, that would be a recommendation from our group, just because of the problems that we've seen. And there was a question about cost. Insurance in general doesn't seem to want to pay for this. It can be ordered by an adult cardiologist, and I think depending on your insurance, sometimes insurance will pay and sometimes insurance will not pay. Here in San Diego, it's $165 out of pocket at San Diego Imaging across the street. It's not a very expensive test, but I don't know about other regions of the country. So those were a couple of the points that I wanted to make. There was also a question about the relationship of arthritis later in life with Kawasaki disease. And we have our group, Alessandra Franco and our group, has looked at some immunologic differences in Kawasaki disease patients that are likely genetic, although we don't have the genetic link figured out yet. But it seems to be an issue of how you control inflammation. And whether or not that difference, that inefficiency in a population of cells called regulatory T cells, whether that is going to predispose people to inflammation type problems later in life, that is not known at this point in time. It's one of the things that we're trying to learn through the adult KD study. So please, everybody sign up. It's just an online questionnaire every other year for 20 years. And we're hoping that we can gather information that will be useful from that survey. So there is not a definite connection to inflammatory disease later in life, but there is a question about it. I guess I would put it that way. Audrey, there was a question about anemia after Kawasaki disease. Why are children anemic? And then is it okay to be anemic 16 months later after IVIG? Sorry.
Yeah, so anemia is seen normally after KD, usually around the 2-week visit when labs are done and the hemoglobin is measured. It's not unusual for it to be a little low. Also during the acute illness, that's well known and well described. So that's a normal small drop. There can also be a relationship between multiple doses of IVIG leading to anemia. We think there's something possibly in the product of how IVIG is made, that with children that receive more than one dose of IVIG, they may be at risk for what we call hemolytic anemia, which is the red cells being broken down actively during the hospitalization. So that is one of the reasons that our center advocates for treatment with something like infliximab instead of giving a second IVIG. That's based on the national trial that Dr. Burns ran, known as KidCare. But then the question about long-term, we do not see long-term anemia. So at 16 months, that is a patient that should be seen by their primary care physician and evaluated for a different cause of anemia, as the KD-related anemia that we see at the 2-week visit is self-resolving, gets better on its own, and doesn't appear to be iron deficiency related.
Kirsten, a question about the duration of anticoagulation therapy. This is a 4.5-year-old who had his aneurysms at age 3.5 and is taking apixaban, and the parents wonder how long he will need to be on apixaban.
Yeah, so I mean, apixaban is used for the giant aneurysm patients. So I'm imagining that your child has giant aneurysms, and as long as the vessels are dilated to that extent, then the child needs to be on systemic anticoagulation. It's like a lifeline for that child, because you want to make sure that the blood is thin enough to move past the areas of aneurysmal dilation. And so as long as the vessels are that dilated, that child will have to stay on apixaban. If the vessels start to remodel to a certain extent, there's a point at which many of us would change from apixaban to two medications that are antiplatelet called aspirin and Plavix, but the vessel would have to remodel quite a bit for that to happen. So as long as it's giant or large, then the child will have to stay on DOACs. And for some people, that's their whole life. But for other people's, they have some remodeling, and then the medications can transition.
And while we've got you, a question about effects on the heart valves from Kawasaki disease.
Yeah, there is, I mean, there are percentages, and I don't remember them all, but Dr. Burns and Dr. Tremoulet would probably remember, but there's a valvulitis, so inflammation of the heart. It can, occur in the vessels, like we talk about the coronary arteries, which obviously we're all very concerned about. It can occur in the heart muscle, called myocarditis, and some of our patients with Kawasaki shock have some inflammation of the heart muscle. That then presents with decreased function, and it can inflame the valves. So we say that that's a valvulitis. Usually the valvulitis is mild in Kawasaki disease. There's like a percentage of kids who have mild mitral valve insufficiency, and then there's a small percentage of kids who have like mild aortic insufficiency, but usually that gets better in the acute phase after treatment. So usually the children leave the hospital with normal valve function and normal heart function. Correct me if I'm wrong.
Yeah, that sounds great. I think the number that people bat around is about 15% during the acute phase have evidence of inflammation in the valves. But as Dr. Dummer said, that tends to resolve over time and have normal valve function after that. There's a question which is totally fair about nomenclature. Okay, so we're talking about dilated and we're talking about aneurysms, and it gets very confusing. And if we controlled the world, what we would like to do is just get rid of all the words and just use numbers, because the numbers, meaning Z-score numbers, are much more informative in terms of prognosis, what the future will hold, in terms of changes over time. And I think that the names and saccular aneurysm and fusiform aneurysm, and people just get really bogged down in the words, whereas what we really care about are the Z-score numbers. So the American Heart Association has made the cutoffs that Kirsten presented in her presentation, that a Z-score of 2 to 2.5, below 2.5, is officially dilated. And I guess what they were trying to convey with that word is that those small changes in the artery are the ones that are most likely to get better, maybe even before the child leaves the hospital. So those are mild changes. And then there's the follow-on question, does that have any meaning or implication for later in life? And as of now, we don't think so. But again, the adult KD study, that questionnaire, there are a lot of unanswered questions about this disease for later in life. And Dr. Bhatt is following patients who know that they've had some problems with their arteries, but whether or not there are things that will crop up later, if we're not following these patients and we're not asking the question, we don't know. But right now it seems like the transiently dilated people are fine. Again, Z-scores are what you want to keep in mind. And that's the easiest way to follow changes over time. And maybe we just get rid of all these words. That's my thought. Jiken, there's a question for you. A parent of a child with Kawasaki disease just had their parent have a heart attack, and they had screening and were taken care of, and they want to know if the heart attack in the grandparent now of the patient is related to the problem of Kawasaki disease in the patient.
So the grandparent has no known history of Kawasaki disease.
Correct, and did not have aneurysms, and it was an adult type heart attack.
Yeah.
Is that related?
So probably not. Just common things being common. We know heart disease is a major problem in the United States, and we know the traditional risk factors are becoming more and more abundant, meaning diabetes, high blood pressure, and all of that. So common things being common, that's the most likely, especially if they had an angiogram that showed kind of your classic plaque built up and that kind of a heart attack. So again, while Kawasaki disease runs in families and we know there's a large genetic component, there's common things still happen.
And from the pediatric point of view, the follow-up to that statement from the adult cardiologist is that you now have declared that you have a family history of typical type heart disease, right? So that means that in order not to pile on problems that are risk factors for adult type heart disease, so here we're talking about classic atherosclerosis or adult type heart disease, it's important in the child who had Kawasaki disease, a different problem, to be vigilant for blood pressure and lipids, so cholesterol panel, and those kinds of screening things should continue to be done to make sure that all the risk factors for traditional heart disease are being considered and mitigated. So that would be a thought. Kirsten, a question about MRI versus CT scans for imaging the coronary arteries.
Good question. I mean, CT scan is the gold standard for coronary arteries. These sorts of advanced imaging inherently are different, and they have different limitations and challenges. So the CTs are used generally to assess the size of the coronary arteries, and also can be used for the calcium score, like Dr. Bhatt had, and we've been talking about today. for us, the MRI is not used to look at coronary artery dimensions, but we do use cardiac MRI to assess the heart muscle, particularly in patients with giant aneurysms and or persistent medium aneurysms. The importance of looking at the myocardium when the children are relatively young, and I mean this before adolescence, is to assess and see if there's any scar in the heart muscle. I think it's what becomes confusing is when you have a young adult who has never had a cardiac MRI, but has some element of residual aneurysms, and then all of a sudden they get an MRI and there's old scar, and nobody knows when that scar occurred. And then there can be kind of knee-jerk reactions to an abnormal MRI. So we tend to document a cardiac MRI in all of our patients with residual aneurysms by the time they're in adolescence, more as a baseline to say, here's where this patient's at, healthy, active, on medications. And it's kind of like a baseline. So the MRI is used to look at the heart muscle, look for scar that might have happened back in the acute illness, really. And the CT is used to look at the coronary artery dimensions for us.
Okay, there's a question about genetics here. And the question about genetics is, do my children have an increased risk of Kawasaki disease? And the answer is yes. The risk is not 0%, and the risk is not 100%. And the risk is somewhere in between. It seems to be low, but we really don't have adequate information because we need more people participating in the adult KD study so we can follow them through the childbearing years and find out what happens to your children. We are establishing a collaboration with a group in Sweden, and this is also potentially possible in other countries that have really good healthcare systems, unlike our country. And the issue there is that in organized health systems where everybody is in a computer database, it would be possible to answer those kinds of questions over time, right? So Kawasaki disease patients could then be followed and find out what happens to their offspring. So we hope to generate those answers to those questions for you through our collaborations with international groups who have access to really great databases, healthcare databases. But it's not something that we can answer at this time, except to say that it's a possibility, but we don't have exact numbers. Okay. Other questions were about, we can scroll down here, sorry. Kirsten, how do you determine when you need 2 antiplatelet drugs versus just 1 antiplatelet drug or aspirin?
Yeah, so one of that has to do with size of the vessel. When the aneurysm or the dilation is mild or it's small, so if you have a Z-score between plus 2.5 and plus 5, we use aspirin only. Once the Z-score is above plus 5, but less than plus 10, we use dual antiplatelet. So that's aspirin plus Plavix. When the children have giant aneurysms, like we said, we use Eliquis, the DOAC, and aspirin. We will actually even add Plavix, which is the other antiplatelet that we use, to that regimen if we see thrombus in the vessel. So there are some patients who are on 3 different medications, but basically it has to do again with the size of the vessel. Now we do have some patients who either don't tolerate aspirin or we don't get the proper aspirin effect, which is measured by a lab value. And then those patients are simply just on Plavix and not on aspirin, but it has to do with the size of the vessel. I also saw a question in there about beta blocker, so I'm just going to briefly mention beta blocker. So different from anticoagulation, beta blocker, I think specifically somebody had asked about atenolol. So the patients where we think about the use of beta blocker are the patients who we feel are at highest risk of ischemia. So obviously in our giant aneurysm population, it would be those patients, because you can imagine if you have a super high heart rate, whether it's because you're exercising or crying or scared or whatever. That doesn't allow for a lot of time to fill your coronary arteries. So the majority of filling of the vessels happens in diastole, which is when the heart relaxes. Obviously, we have blood flow in our coronaries throughout the cardiac cycle, but the beta blocker is used to blunt the high heart rates in patients who we are most worried about ischemia in. So we use them on a case-by-case basis. It's not algorithm-based. It is really based on how worried we are about ischemia, and also the patient's age plays a role. So there are some patients who don't tolerate beta blocker because of the side effects of it. The vast majority of our patients do tolerate beta blocker, but it needs to be used responsibly, and they need to be educated about how you can't acutely withdraw it. And so there's some discussions around the use of beta blocker, and it works for most of our patients who need it. And so that's what I would say about beta blocker.
Jiken, do you want to add in the adult population, what the indications in Kawasaki aneurysm patients are for beta blockers?
Yeah, I agree with Dr. Dummer. I think it's pretty similar as how we use them. A lot of it we extrapolate from our non-Kawasaki disease patients. So patients who there is limitations to blood flow, patients who are having symptoms from their aneurysms, patients who may have developed heart failure as a result of heart attacks in the past. All of those patients will get a beta blocker long term. But in general, in both the Kawasaki and non-Kawasaki disease patients, for patients who just have coronary artery disease or have aneurysms, we don't routinely just put them all on a beta blocker if they don't have any symptoms or any limitations to the blood flow to the heart muscle.
Right, thank you. Kirsten, there seems to be some confusion, which is totally understandable, between a CT calcium score and a CT angiogram. Can you talk about those differences?
Sure. So a CT calcium score is just a flash scan looking for calcium. So it's not defining anything else. It really just kind of shows you what lights up with calcium. And where that is, then the radiologist knows kind of what vessel that might be in. But what you don't see with the CT calcium score is you don't see the definition of the vessels, because they're not using contrast in the CT calcium scores. You can have a CT angiogram with calcium score, which is often how we order the studies in some of our adolescent patients, because we are both interested in the size of the vessel. That's the angiogram part where they give contrast. And we're interested in, is there any calcium in the wall or in that vessel? So you can order one without the other, or you can order them separately. They are different things. CT angiogram gives you the lumen size of the vessel and gives you the big outline and the pretty pictures I showed. And a CT calcium score is just the bright white that shows you where the calcium might be. And probably Dr. Bhatt and other people have more to say about that, but that's how I think about it.
Yeah, I think about it the same way.
I went back and looked at a question, and the person that I thought was the grandmother of the KD patient turns out actually to be the mother of the KD patient. So I am now presuming that since your child is 2.5 years old, you are a young-ish person, and you had a coronary angiogram and a CT scan and a treadmill test. So, Kirsten, could you talk about the difference between a treadmill test and a stress echo?
Sure. So a treadmill test is when you're running on the treadmill and you're hooked up to the EKG. It's really looking at your EKG and the tracings that are obtained before exercise, during exercise, and after exercise. And there can be ischemic changes on the EKG that kind of tip us off to knowing that there is a coronary problem. So
what's ischemia?
Ischemia is decreased blood flow to the heart muscle. So when you're running on the treadmill or bicycling and you're hooked up to the EKG, which are the little stickies across the anterior part of your chest, that is what that information tells us. It tells us your heart rate, it tells us if you have any arrhythmias, and it tells us if you have changes on that EKG that can be consistent with decreased blood flow to different parts of your heart muscle. When we ask you to hop off of that and lay on a table and we do an ultrasound of your heart, which is how we do our stress echoes from a bicycle test to the table, then we are taking the ultrasound probe and we are watching your heart squeezing. And what we're looking for is every segment of the heart muscle on the right side of the heart and on the left side of the heart, we're watching it squeeze when your heart rate is very fast at peak exercise. So it is it needs to be interpreted by a skilled person. So we have one person in our institution at Rady Children's who reads all of the stress echocardiograms, because there's a little bit of an art to interpretation, but when you are the person looking at all of them, you're very skilled at noticing subtle changes of the heart muscle. And so the stress echocardiogram adds the component of watching each segment of heart muscle squeeze and making sure that it thickens appropriately with exercise.
Okay. I see that we are getting past the hour and we should be respectful of everybody's time. There were some more questions that we didn't get to, but we can answer them by email, or we can answer them by typing in some answers here. But I want to be respectful of people's time and thank everybody for participating, all of our amazing participants who gave talks today, all of our audience who chimed in with great questions. We really appreciate everybody's time, and we look forward to doing this again next year with a new group of people. Please watch the video that Kieth Solomon has produced and pass it on to your cardiologist. And we will see you again next year. Thank you so much.
I was going to try to put the AHA guidelines in here, if I can.
Okay.
And leave it open. Somebody asked, but I'm just going to stick it in here.
Okay.
And for those wondering, the video and all what we've talked about today is on the University of California, San Diego Kawasaki Disease Research Center website. And also the video for adult cardiologists is on there. It's also on YouTube.
And it is also on the KD Foundation website.
Right.
So we're sending out that video all over so that adult cardiologists can become educated about the care of this disease. So thanks again to everyone.
All right. Bye-bye.